Thank you, everyone. It's 45 minutes after the hour, and we will now reconvene the ACIP meeting. Next up, we have Dr. Sarah Oliver, who will be speaking on evidence to recommendations framework for the bivalent COVID-19 vaccine booster doses. Dr. Oliver, if you're ready.
I am. Thanks so much. Good afternoon. Next slide. Next slide. So you guys are well aware of our evidence to recommendation framework, describing the totality of the information considered in moving from evidence to ACIP recommendations. Next slide. This is the ETR framework as we have seen before. However, I do want to highlight the equity domain. As you've seen as we've walked through numerous ETRs to date, we've really had trouble answering a single question for equity to highlight the impact of the intervention on health equity. Next slide. So for the last several months, we've been engaged with a review of the equity domain and gathered input and feedback through consultation with health equity experts and other partners, such as the National Medical Association, the Office of Minority Health and Health Equity. Throughout this process, it's become clear that consideration of equity is integral to every aspect of the production, study, authorization, and recommendation of COVID vaccines. Next slide. The need for a systematic, reliable, and action-oriented review of evidence towards enhanced equity was also made clear, that structural problems require structural solutions. The adjustment of the structure is required for meaningful change, and an adjustment of the ETR framework to enable systematic and reliable review of evidence towards actionable recommendations to enhance equity may help facilitate meaningful change. Therefore, for at least today's presentation, we have proposed a change to the equity domain, now as a consideration across each other ETR domain. We recommend a systematic, reliable inclusion of data to speak to the equity considerations in each domain, both to demonstrate the data and encourage actions needed to enhance equity as relevant to each domain. Therefore, for today, we will remove the voting question on equity and will enhance attention to equity across all the other domains. Next slide. This will be an iterative process that will require feedback from ACIP and others. We will then take this feedback and continue with the process for future ETRs, but this is the ETR framework that we'll walk through today. For each of the domains, we will address an equity question for that specific domain. Next slide. So then for this ETR presentation, as you've heard previously, the EUAs are issued for the bivalent Pfizer vaccine in those 12 and over, and the bivalent Moderna vaccine for those 18 and over. We'll have votes for those specific vaccines and age groups specifically, but we're also asking ACIP to consider the larger question. Does ACIP support the use of updated or bivalent COVID-19 vaccine booster doses for those individuals and age groups already currently recommended to receive a COVID-19 vaccine booster? Next slide. On the left are the current recommendations, where the focus was on counting dose numbers, and those 5 through 49 years are recommended for 3 doses, and those 50 and over were recommended for 4 doses. On the right is overall future proposed recommendations, where individuals recommended for a primary series and a bivalent booster dose, regardless of the previous booster doses given. Age and vaccines for this will be as authorized by FDA and recommended by ACIP and CDC. So this is not necessarily the recommendations today, but where we envision the future of the program going. We'll hear from Dr. Hill later today around the details for the schedule, but I wanted to orient us to the broader discussion that we hope to have for today. Next slide. Next slide. So this figure shows the daily trends in reported COVID-19 cases. As of August 29th, there have been over 94 million COVID cases reported to CDC. Next slide. We've seen this previously, but this figure shows the weekly trends in COVID-associated hospitalization rates by age group from COVIDNet. Hospitalization rates peaked for all age groups during last winter's Omicron wave, and since April, hospitalization rates in older age groups have increased relative to the other age groups. Next slide. Here again, we see the age-adjusted rates for COVID-associated hospitalizations by vaccination status among adults. In June, unvaccinated adults had 4.6 times higher COVID-associated hospitalization rates compared to those who were vaccinated with at least one booster. Next slide. Then this figure shows the age-adjusted rates of COVID-associated deaths by vaccination status. In June, unvaccinated people ages 5 and over had 8 times higher COVID-associated death rates compared to those with at least one booster dose. Next slide. Then when we focus in on death rates by vaccination status among people 50 years and over, we see that in June 2022, people with two booster doses had 14 times lower risk of dying from COVID compared to unvaccinated individuals, and a 3 times lower risk of dying from COVID than people with one booster dose. Next slide. So moving to our vaccination data, here we see the trends in the cumulative percentage of the US population vaccinated with a primary series by age group. Persons aged 65 and over in the dark orange have the highest coverage at 92%. Then the coverage decreases as age decreases, with the lowest coverage among ages 5 through 11 years in dark blue at 30%. I'll note that individuals 6 months through 5 years of age are also recommended to receive a vaccine, but aren't yet on this figure. Next slide. Here we see a similar figure with trends in coverage for first booster doses by age group. Again, we see the highest coverage among those 65 and over, and the lowest coverage among persons 5 through 11. Next slide. And then if now we take a look at trends in coverage for second booster doses by age group, again, the highest coverage is among those 65 and over, but overall only 41% have completed a second booster. Next slide. So now for the equity question for this domain, does the problem impact all populations equally? Next slide. This slide shows COVID case and death rates in the US by urban or rural classification. In the recent Omicron surge, the case rate on the left was higher among the large metro classification, while the death rate on the right was higher in the rural population. Next slide. You can also see here weekly cases by race and ethnicity. Throughout the pandemic, we have seen cases higher among racial and ethnic minority populations. Next slide. This slide also shows COVID hospitalizations by race and ethnicity. When we look at hospitalizations, we can also see that hospitalizations are higher among racial and ethnic minority populations as well, although it was more pronounced earlier in the pandemic. Next slide. Then for COVID-associated deaths, again throughout the pandemic, mortality rates have been higher, again among racial and ethnic minority populations. Again, they were more pronounced earlier in the pandemic. Then as highlighted in the box, the recent mortality rates show less evidence of these disparities. Next slide. So in summary, as of August, over 94 million COVID cases have been reported in the US. Since April, hospitalization rates in older age groups have increased relative to other age groups. In addition, in June, during Omicron predominance, unvaccinated adults 18 and over had 4.6 times higher hospitalization rates compared with those who received at least one booster, and unvaccinated individuals 5 and over had 8 times higher death rates. We know that vaccination rates are much higher among older adults relative to the other age groups. And we know that people of racial and ethnic minority groups have been disproportionately burdened by COVID-19 illness, hospitalization, and death. Next slide. So the work group felt that yes, COVID is of public health importance, especially among populations recommended to receive a booster. Next slide. Now to benefits and harms. Next slide. So first we'll review the clinical trial data. Then we'll also review other considerations to emphasize that we're reviewing the totality of the data able to inform these recommendations. Next slide. This highlights the available clinical trial data First from the Moderna bivalent booster clinical trial and then from the Pfizer BioNTech trial, both of which investigate vaccines comprising an ancestral and BA1 strains. There's no international data yet available for bivalent booster and no clinical trial data for bivalent boosters with BA4-5 yet. Next slide. So in the Moderna phase 2-3 trial, persons were given a 50 microgram bivalent boost, again, which was 25 micrograms each of ancestral and Omicron BA1 spike, as a second booster vaccine, and were compared to those given the ancestral booster as a second booster. The trial participants were in adults 18 and over. 437 participants received a bivalent booster, 377 received an ancestral booster. The dosing interval from first booster to the bivalent was 136 days and 134 days for the ancestral booster. And the median follow-up was 40 to 57 days. Next slide. Immunogenicity was assessed by the antibody response on day 29 after the study vaccination. Based on the geometric mean ratios, comparing the antibody response in participants that received the bivalent booster to those that received the monovalent ancestral vaccine, the bivalent vaccine met superiority criteria for both Omicron and ancestral SARS-CoV-2 antibodies. Next slide. The superiority criteria were also met in participants with or without evidence of infection on day 29, with the highest geometric mean titers observed in those with prior infection on the far right. Next slide. Local reactogenicity with the bivalent booster as a fourth dose was similar to the second and third doses of the ancestral Moderna vaccine. The most commonly reported grade 3 local reaction was redness. Systemic adverse reactions with the bivalent vaccine were lower than systemic reactions from second and third doses of the ancestral vaccine. And the most commonly reported systemic adverse reaction was fatigue. No grade 4 events were reported in the trial. Next slide. This graph shows the percentage of participants reporting local or systemic reaction following vaccination with the Moderna bivalent vaccine. Next slide. There were no serious adverse events assessed as related to the vaccine. 2 participants experienced 2 serious adverse events, 1 prostate cancer diagnosis and 1 traumatic fracture within 28 days of the booster dose. There were no deaths or adverse events of special interests, including no cases of myocarditis or pericarditis. In the bivalent booster group, all severe events included reactogenicity events, and 1 patient reported lymphadenopathy. Next slide. So now moving to the Pfizer BioNTech bivalent booster clinical trial. Individuals received a 4th dose of a 30 microgram bivalent vaccine comprised of ancestral and an Omicron BA1 strain, and were compared to those that received a 4th dose of 30 micrograms of the ancestral monovalent vaccine. The study evaluated safety and immunogenicity among participants aged 55 years and over. 305 participants received the bivalent Omicron vaccine, and 305 received the monovalent ancestral vaccine. The dosing interval from the first booster to the second booster was 6.3 months, and the median follow-up was 1.7 to 1.8 months. Next slide. Again, immunogenicity was assessed by the antibody response 1 month after the study vaccination. Based on the geometric mean ratios comparing the antibody response in participants that received the bivalent booster to those that received the monovalent ancestral vaccine, the bivalent vaccine met superiority criteria for Omicron antibodies and non-inferiority criteria for ancestral SARS-CoV-2 antibodies. Next slide. In participants over 55 years of age, local and systemic reactogenicity with the Pfizer bivalent vaccine were similar to the prototype vaccine. 4 participants reported fever between 38.9 and 40 Celsius in the vaccine group, and no grade 4 events were reported. Next slide. Then these graphs show the percentage of participants reporting local or systemic reactions following vaccination with the Pfizer bivalent booster. Next slide. No adverse events were assessed as related to the vaccine. There were no life-threatening adverse events or deaths reported by participants. No cases of anaphylaxis, hypersensitivity, myocarditis, pericarditis, appendicitis, or other adverse events of special interest. In the bivalent booster group, all severe events included reactogenicity events such as fatigue, chills, arthralgia, and headache, and some mild to moderate events of lymphadenopathy were also reported. Next slide. So a summary of the clinical trial data. A bivalent booster dose of both Moderna and Pfizer COVID-19 vaccines increased the immune response in those who've completed a primary series and a previous booster. Compared with ancestral booster dose, the bivalent booster doses demonstrated a superior response to Omicron and either a superior or non-inferior response to ancestral. The bivalent booster doses had a similar reactogenicity profile to the primary series and to an ancestral booster dose. It should be noted, though, that the data from the clinical trials are limited in size, age, and bivalent booster type. Next slide. So now we'll move to other considerations. We'll present available data to assess the potential risk of myocarditis following a bivalent booster dose. The risk of myocarditis following a bivalent booster dose is unknown, and there's limited data from second booster doses of the current COVID vaccines, as it's recommended for adults over 50 years of age. So we'll review the risk of myocarditis following a second dose in a primary series and the first booster dose. Next slide. Here we present the VAERS reporting rates for verified myocarditis per 1 million mRNA COVID-19 vaccination in the 7 days post-vaccination. The rates that exceeded the estimated background rates of myocarditis in the same interval are indicated by the peach shading. This is the same slide that was shown by Dr. Shimabukuro earlier. Next slide. These are the incidence rates of myocarditis and pericarditis following primary series and booster dose in another surveillance system, the Vaccine Safety Data Link, 0 to 7 days after Pfizer vaccination. Next slide. And this is the same data following primary series and booster dose after Moderna vaccination. Again, these are the same slides that were shown in Dr. Shimabukuro's presentation. Next slide. Then this slide is from surveillance data in Ontario, Canada, demonstrating their reporting rates per million doses administered. In the box on the right, we see the myocarditis rates after dose 2 and dose 3 in males. You can see that across all ages, the rates of myocarditis are lower after a booster dose than after dose 2 of the primary series. Next slide. This slide is from the long-term follow-up study for myocarditis participants and was previously presented to ACIP. As a reminder, at least 90 days after the myocarditis diagnosis, most patients who were reached reported no impact on their quality of life, and most did not report missing school or work. And of the healthcare providers who completed the surveys, indicated the patients were fully recovered or probably fully recovered. Next slide. So in summary, around myocarditis and pericarditis, we know that the risk of myocarditis has been identified after COVID vaccine. This risk is rare and primarily observed in adolescent and young adult males. Among the VAERS data, the reporting rates of myocarditis are lower after a booster dose compared to the primary series. Among VSD data, the incidence following dose 2 of a primary series and a booster dose are similar, but the case counts are small. Among surveillance data from Canada, what indicates that the risk of myocarditis or pericarditis following the first booster dose appear lower than the risk following the second dose of the primary series. And this was observed for both Pfizer and Moderna products across all age groups. Most individuals with myocarditis and pericarditis had fully recovered at follow-up. And we know that using data from pre-Omicron estimates, the risk of adverse cardiac outcomes were 1.8 to 5.6 times higher after SARS-CoV-2 infection than after mRNA COVID vaccination among males in that 12 to 17-year age group. And we've also discussed previously at 8 weeks that we know an interval, we've discussed previously at ACIP, we know that an interval of 8 weeks between vaccine doses may further lower the myocarditis risk. Next slide. Then this is from the COVID-19 Vaccine Safety Technical Group that closely reviews data from U.S. safety monitoring systems as well as from other sources. And this is their report. Through August, they had held held 64 teleconference meetings. This is their interpretation of the safety data with a special focus on myocarditis. Overall, they felt that for V-Safe, the reactions and health impacts were not higher after a booster dose than after a primary series. For VAERS, there were no additional concerns, and that the myocarditis reporting rates were lower after a booster dose than a primary series. For VSD, there were few myocarditis or pericarditis cases after booster dose, and the risk estimates were imprecise. The risk after booster doses appeared similar to the risk after the primary series dose 2. VAST also reviewed additional vaccination data in pregnancy, and no safety concerns from any of the systems that have data on primary series and the first booster dose. Then, as always, VAST will continue to closely review the safety data, including data after a bivalent vaccine booster once available. Next slide. So now moving to other additional considerations. To better understand the impact of a fall booster rollout, we'll look at projections from the COVID-19 Scenario Modeling Hub. The Scenario Modeling Hub is a multi-team effort aimed at creating and modeling planned scenarios for the mid to long-term COVID-19 situation. There are typically 5 to 10 submissions per scenario round at the national level, and results are ensembled and summarized by the hub. Round 14 and 15 were planning scenarios were projecting COVID-19 burden through mid-2023 under different booster policies that I'll walk through. Next slide. This slide details the scenarios for each round. In round 14, the VE of the bivalent boosters was assumed to be 80% against symptomatic disease with non-immune escape strains. The scenario included a targeted booster campaign in ages 50 and over versus a flu vaccine-like uptake in ages 18 and over, and also looked at no variant versus a fall variant X with a 40% immune escape and 20% increased severity. Then round 15 was a rapid round aimed to update round 14 and consider booster dose timing. The same VE and variant assumptions were used as round 14, but assumed booster recommendation with flu-like uptake in 18 and over, starting in September versus starting in November. Next slide. The round 14 national ensemble projection intervals showed that regardless of the presence of a new variant, influenza vaccine-like uptake in individuals 18 years and over would lead to over 20% reduction in hospitalizations and over 15% reduction in death versus a recommendation for individuals aged 50 and over only. Next slide. The round 15 national projection intervals showed that absent a new variant, boosters to individuals 18 and over in September could prevent over 100,000 more hospitalizations and nearly 10,000 more deaths compared to a booster rollout in November. Next slide. So we've previously discussed immune tolerance and concerns for COVID-19 vaccine booster doses. As a reminder, immune tolerance is the concern that giving additional doses of COVID-19 vaccine would lead to lower antibody levels or a failure to restore antibody levels to what was seen after a previous dose, or T-cell exhaustion. However, again, we aren't seeing data at this point to suggest that this is occurring. Bivalent vaccine is able to improve vaccine titers in individuals without prior infection and also provided robust boost in antibody titers for individuals with prior infection. As you can see here on the right, we continue to see high antibody titers for the bivalent vaccine prior to SARS-CoV-2. You can see here on the right, the high antibody titers that we see for this bivalent vaccine plus prior infection could lead to slower waning and prolonged protection against COVID-19 and severe disease. Next slide. We also had discussed imprinting previously. Imprinting, sometimes known as the original antigenic sin concern, is the concern that the initial exposure to one virus strain primes B-cell memory and limits the development of memory B cells and neutralizing antibodies against new strains. However, data suggest an improved diverse response obtained with bivalent vaccines. Antibody titers to all SARS-CoV-2 variants tested were higher with the bivalent vaccine compared to the monovalent ancestral vaccine. Next slide. Then we heard from Dr. Thornburg earlier around antigenic cartography, or ways to map out the antibody responses. Antigenic cartography uses 2D and 3D maps to visualize how closely related the antibody responses are for different viruses. An example of this with SARS-CoV-2 is in the figure on the left. Antibody landscapes are another form of cartography, and they evaluate the diversity of the immune response. The landscapes are the things that look like different color sheets of paper in figures D and E. A flat landscape is better, as it indicates that the response to all viruses or variants are similar. When the sheet of paper or the landscape is sloped, as you can see at the bottom of panel D, it means that the responses were very skewed to one particular variant. For this study that was done by the NIH, they looked at antibody responses on day 15 after giving a variety of vaccines, including several different bivalent vaccines. For the day 15 antibody response, which is the top sets of the landscapes, and especially for those with a history of prior infection, which is shown in panel E, the bivalent vaccines with a prototype plus Omicron composition, which is the landscape at the top shown in purple, provided the best robust response that was diverse and similar across the different variants. Next slide. So now we'll talk a little bit about Omicron itself and what it means that we're talking about bivalent Omicron vaccines, and a little bit around the differences between BA.1 and BA.4/5. As we've discussed, the clinical data from the bivalent vaccines are primarily obtained using BA.1. Here's a little bit about what that means and the difference. Compared to the ancestral virus, which was circulating in early 2020 and is what is currently in the monovalent vaccines, all Omicron sublineages have shared mutations, highlighted here in the black arrow. Many of these mutations are in the receptor binding domain, highlighted in the box with RBD. The receptor binding domain, as the name implies, is the primary binding site for antibodies. These mutations contribute to decreased neutralization and increased transmissibility for the Omicron sublineages. So any vaccine that uses any Omicron subvariant would include all of these mutations. Next slide. So what about the differences between BA.1 and BA.4/5 specifically? First, I want to clarify why there are two numbers, why we say BA.4 and BA.5. BA.4 and BA.5 are two different Omicron sublineages, but the spike protein for each, which is the focus of the vaccine, is identical. So what we're talking about in the vaccine is the spike protein for both BA.4 and BA.5, but it is still just one single sequence, not two different ones. Then the bar at the top for BA.1, and then there's the bar at the bottom, is BA.4/5. The numbers and letters seen are areas where they differ from the main virus of comparison. The text you can see on the bottom right lists all the differences between BA.4 and BA.5. Without this sounding like an organic chemistry class, the figure highlights where several of these are in the red arrows. Overall, as you can see, there are differences, but they fundamentally are not a completely new or different virus. They actually share most of the same genetic code, except the highlighted red differences. Next slide. So we'll get out of the chemistry lessons and much more back to traditional vaccine data. We fully acknowledge that we're in a different position now than we were in 2020 or 2021. Within the 2 years of the pandemic, especially the recent Omicron surges we've seen for the past year, many of us have also had a SARS-CoV-2 infection. We saw on the previous slides how that impacted the antigenic landscapes, but now we can look at how that impacts vaccine effectiveness. This is a study from Qatar, looking at VE with 2 or 3 doses of mRNA vaccines with or without prior infection. The figures are similar, just looking at Pfizer on the left and Moderna on the right. And you can see that in both figures, the point estimate on the far right, the hybrid immunity that's shown in the orange square, having 3 doses of the vaccine and having prior infection, those individuals were the most protected, having a VE of near 80%. The effectiveness of prior infection alone was around 50%. Next slide. Then as we saw with Omicron, the risk of reinfection fundamentally changed during the Omicron surge as well. This study looked at electronic health records in the US and looked at risk of reinfection through the calendar months. As you can see at the figure on the right, as we went into the Omicron surge, the risk of reinfection significantly increased. Next slide. So then while today's discussion is primarily focused on the bivalent mRNA vaccines, we are asking you to consider the broader program as well. So I wanted to briefly provide some information on non-mRNA boosters. At this time, the published data are limited, but we'll show what we have. The study looked at a handful of individuals who received a Novavax primary series and a booster in teal, highlighted in the middle, compared to those who received the original monovalent mRNA vaccines in dark blue on the left. I'll note we don't have any data to compare what this would look like with the updated bivalent vaccines, but we can see the responses overall were fairly similar to what was seen with the monovalent mRNA vaccines. Although I will note that this was only with 4 or 5 individuals in the Novavax group. Next slide. This study then looked at various booster doses given after being primed with 2 doses of a Pfizer vaccine. The study had a randomized third trial given of various boosters given 10 to 12 weeks. All booster doses resulted in an increase in anti-spike IgG concentration. But you'll notice that third doses of the mRNA vaccines resulted in geometric mean concentrations that were about 3 times higher than those observed in the Novavax booster recipients. And all boosters in the study showed acceptable side effect profiles. Next slide. So now to the equity questions for this domain. Next slide. I'll note the equity question for this domain is, are the desirable and undesirable anticipated effects demonstrated across all populations equally? This language was very specifically chosen. First, were they demonstrated across all populations? Were the persons of diverse race and ethnic backgrounds included in the clinical trials? Do the demographics reflect the demographics of the US population? Then are the effects equally demonstrated? Were the desirable or undesirable effects evaluated by population groups? And do they differ in any of those population groups? For all future ETRs, we commit to evaluating the benefit-risk data through this lens as well. Next slide. So we'll highlight that this is the demographic makeup of the Moderna clinical trial for the bivalent vaccines. It consisted of a smaller percentage of Hispanic and Latino participants than that make up the US census data. Likewise, the trial was comprised of a larger proportion of white participants than the US population. Next slide. This is similar data for the Pfizer trial. And similarly, the Pfizer trial had less racial and ethnic diversity than the US population. Additionally, because the trial was conducted in persons older than 55 years, the median age of the trial participants was obviously much higher than what is seen in the US population. Next slide. So then for results by race and ethnicity, the Moderna bivalent vaccine demonstrated that Omicron BA.1 and original strain neutralizing antibodies after the 4th dose were comparable across racial groups. In the Pfizer-BioNTech trial, subgroups of participants 55 or over 55 in the safety population generally had similar adverse event profiles from steady vaccination to 1 month post-dose. Across various vaccine groups when evaluated by subgroups of sex, race, and ethnicity. And overall, there were no meaningful differences between the subgroups for the Omicron variant or the original strain. However, it should be noted that in both trials, the subgroups of race and ethnicity included a limited number of participants, and so results should be interpreted with caution. Next slide. So overall, we'll summarize what data we have to inform the recommendations as it relates to benefits and harms. We have experience from using COVID-19 vaccine mRNA platforms for nearly 2 years, over 600 million doses in the United States alone. We have extensive vaccine effectiveness studies as well as robust post-authorization safety data across multiple platforms. Clinical human data from bivalent COVID-19 vaccines are available in over 1,700 persons. This includes bivalent vaccines with both Beta and Omicron variants, and both from manufacturers and NIH studies. Over 1,400 individuals received a bivalent vaccine with the Omicron component specifically. Then, as we discussed, there are subtle differences in mutations between the BA1 and BA4-5 spike protein sequences. But overall, we don't anticipate that we would see differences in safety or reactogenicity of the vaccines based on these limited mutations. The overall composition of the vaccine, as well as the total antigenic load, are the same as the current booster doses. Then we also reviewed data from the Antigenic Cartography and antibody studies, as well as modeling data. Next slide. So here's what we know. COVID-19 vaccines have a high degree of safety. We know that there are rare events of myocarditis that have been seen after the mRNA vaccines and post-authorization studies, and cases of myocarditis that have been attributed to the vaccine in the Novavax clinical trials. But we know that they have a high degree of safety. COVID vaccines also provide high levels of protection against severe disease. Initially, the COVID vaccines also provided high levels of protection against infection and transmission. However, as the virus evolved, we noted more rapid waning of protection against asymptomatic and milder disease. We know that COVID booster doses further increase protection against severe disease. And we know that the bivalent COVID vaccines expand the immune response after vaccination. Vaccines that contain Omicron will improve the antibody response to Omicron. And bivalent vaccines appear to provide a more diverse response overall, which may actually improve the immune response to future variants as well. Next slide. It is important, however, to acknowledge what we don't know. Right now, we don't know the rates of myocarditis after bivalent COVID-19 vaccines. It's unlikely that the inclusion of Omicron would increase myocarditis rates. What we know that does impact myocarditis is age and sex of the individual, intervals since previous dose, and potentially total dose may be related. But it's unlikely that the inclusion of Omicron would have an impact. We don't know the incremental increase in vaccine effectiveness. Antibody titers to currently circulating variants were higher after a bivalent booster dose than with the current monovalent booster. However, most of the data to inform recommendations were from that BA1 bivalent vaccine. The incremental benefit from going from BA1 to BA4-5 are unknown. We also don't know the duration of protection for these vaccines. However, antibody titers after bivalent vaccine and prior infection were robust. This combination of prior infection and the bivalent vaccine may prolong the duration of protection, which could actually decrease a need for frequent boosters. However, as with all vaccines, the duration of protection may vary by age and immune status. Next slide. So in summary of the balance of benefits and risks for these bivalent vaccines, we know that for both Moderna and the Pfizer BioNTech vaccines, the bivalent vaccines increase the immune response for those who've completed a primary series and previous booster. We saw similar reactogenicity profiles. We know that the myocarditis risk is unknown, but anticipate a similar risk to what's seen after the monovalent vaccines. We know that the modeling projects more hospitalizations and deaths would be averted when booster doses are recommended broadly for persons 18 and over compared to those 50 and over, and when the booster campaign would begin in September compared to beginning in November. We also know that the benefits and harms for the U.S. population are best assessed when the clinical trial and study populations are optimally representative of the U.S. population. Next slide. So the work group felt that the substantial desirable anticipated effects were moderate. Next slide. The undesirable anticipated effects were small. Next slide. And that the balance of those favored the intervention. Next slide. Now moving to values. Next slide. This slide shows survey data from an online survey conducted in partnership with CDC and the University of Iowa. You've seen results from this partnership frequently over the course of several ETRs. This survey was conducted very recently over the month of August and showed that 72% of eligible respondents said that they definitely or probably would get an updated booster that protects against Omicron. Next slide. Among people who said that they were unsure about getting a booster, people both felt that they have enough protection from their prior dose or that the booster may not be effective. Next slide. However, when asked why people would get a booster, preventing them from spreading to others and preventing severe disease were the most common. Next slide. Then as we move into fall, we know that implementation of a COVID booster program will overlap with the influenza vaccination season as well. Here we have data around co-administration of COVID and flu, and we'll hear more about the data in trials to look at that. But for this, when survey recipients were asked if they would be willing to get a flu shot and the updated COVID at the same time, 63% of individuals were extremely or somewhat willing to receive them together. Next slide. So now for the equity question for this domain, is there important variability in how patients or populations value the outcome? Next slide. Booster uptake has remained relatively steady, with those groups with higher initial vaccine uptake also more likely to have received their booster dose. This means that older adults, college graduates, and those with higher incomes remain the most likely to be both vaccinated with the primary series and boosted. There is notable difference, though, in the vaccinated with the primary series versus boosted status among adults of Hispanic or Latino ethnicity. Despite a high vaccine uptake, around a third of these adults who say that they've completed a primary series have not yet received a first booster. Next slide. Then this shows information for why people have not received a booster, this time shown by race and ethnicity. You can see a higher proportion of vaccinated but unboosted adults of Hispanic ethnicity feel that they have enough protection from prior infection or may have had side effects from previous doses or could be worried about missing work from the symptoms post-vaccine. Next slide. So in summary, the value of this intervention appears high to most of the population. 72% of survey respondents reported that they were likely to receive an updated booster, with the prevention of spread to others and a change in case severity appearing to lead as the main reasons why they would want to get an updated booster. We also know that nearly 2/3 of adults were willing to receive a COVID vaccine and a flu shot at the same time. However, we know receipt of a booster to date demonstrates persistent vaccine inequity. Adults of older age, those with college degrees or higher income, remain most likely to be vaccinated with a primary series and booster. Notably, about a third of Hispanic or Latino ethnicity adults have not yet received a booster despite completion of a primary series. Next slide. So the work group felt that the target population felt that the desirable effects were moderate relative to undesirable effects. Next slide. However, there is probably important uncertainty or variability. Next slide. So now to acceptability. Next slide. As we think through the acceptability of bivalent boosters, we can think through the COVID vaccination program overall. There have been over 800 million doses delivered to date. Over 600 million doses have been delivered. Over 90% of the population has received at least one dose, and over 223 million individuals have completed a primary series. Next slide. We have a broad network of COVID vaccine providers, including critical pharmacy providers, federal partners, as well as jurisdictional providers. Next slide. Then for the equity question for this domain, is it the intervention equally acceptable across all populations? Next slide. So taking a look at the percentage of the population with a completed COVID vaccine primary series by race and ethnicity over time. As shown here, Asian, American Indian and Alaskan Native, Native Hawaiian, or other Pacific Islander populations have the highest percentage among those who are fully vaccinated or have completed a primary series, whereas the Black populations have the lowest vaccination to date. Next slide. As it pertains to booster vaccination trends by race and ethnicity, multiracial and Asian populations have the highest percentage among those who've received their first booster dose, and second booster dose receipt is higher again among multiracial populations relative to other racial and ethnic groups. Next slide. We see that there have also been disparities by population for those who've completed a primary series by county urbanicity, with those in large metro areas having a higher vaccination than those in rural populations. Next slide. Then we'll also see that vaccination rates vary by both race and ethnicity and disability status. On the far left, you can see that vaccination rates for those assessed as having different abilities with vision, hearing, mobility, or cognition have lower vaccination rates. And you can see how this varies by race and ethnicity as well. Next slide. We've shown throughout ETRs before that a provider's recommendation remains very important to COVID vaccine acceptance. And this importance appears highest among individuals who are over 65, Black, retired, or with incomes under $30,000. This indicates that the potential for healthcare providers to increase the acceptability of these bivalent vaccines through communications with their providers. Next slide. So in summary, we know that over 800 million doses of COVID vaccines have been delivered across a wide network of vaccine providers. However, significant disparities in completion of the primary series and receipt of booster doses still persist by race and ethnicity, urbanicity, and differences in abilities, including vision, hearing, mobility, and cognition. However, it's important to note that the detection of the disparities does not necessarily explain the disparities. Differences in acceptability can be what contributes to the disparities. But as we heard frequently through listening sessions when we were revising the equity domain, we heard caution against explaining all disparities as vaccine hesitancy or low acceptability, when there may be other drivers also present. Differences in access may contribute to these disparities, as many others may as well. Identifying and understanding these and other drivers of inequity is a critical step towards closing these equity gaps, and we have further work to do here. In the meantime, we know healthcare provider recommendations are important and continue to appear to increase the acceptability of COVID vaccination, particularly among adults who are Black, over the age of 65, retired, and of lower income. Next slide. So the work group felt that the vaccine is probably acceptable to key stakeholders. Next slide. So now moving to feasibility. Next slide. Here we see trends in completed primary series and first boosters for persons age 5 through 11 in purple, 12 through 17 in orange, and 18 to 49 in blue. And you can see the primary series is the darker shade of those colors, whereas the first booster receipt is a lighter shade. For most individuals, ages 5 through 49 years, you can see that it's been 6 months or more since their last COVID vaccine dose. Next slide. Here we see the trends in completed primary series, first and second boosters for persons aged 50 to 64 years in orange, and then 65 or over in blue. While many have received a second booster in the past 6 months, you can see comparatively few have received a dose in the past 8 weeks. You can also tell that overall the numbers have declined with each of the booster recommendations as we've progressed. Next slide. This actually shows that in September, based on the total number of persons eligible, which includes those who've completed a primary series but not received a COVID vaccine in the past 2 months, consistent with the language in the EUA, is almost 210 million individuals, while the number ineligible, which would be those who had a vaccine dose in the past 2 months, is less than 5 million. Next slide. Overall, the US government has purchased approximately 171 million bivalent mRNA vaccine booster doses for the fall and beyond, with the options to purchase additional doses as needed. Based on this, there will be a sufficient but finite supply of these vaccines. We do not anticipate limited supply settings overall. However, jurisdictions have been given considerations for selecting sites to receive the initial doses based on ability to rapidly use the vaccine. These considerations were in the operational planning guide provided to jurisdictions with the link at the bottom, and they include location and access to a range of populations to ensure equitable distribution, the ability to reach those at highest risk of COVID, the ability to handle the large product shipments, and the ability to administer the vaccines. Next slide. We'll hear more from Dr. Hall in the next portion of the presentation around these details. But overall, the bivalent vaccines have the same storage and handling parameters as the monovalent vaccines that they're used to handling. However, both manufacturers' bivalent vaccines will have gray label borders, but different injection volumes. And again, Dr. Hall has pictures with much better details, but I'll note that the monovalent and bivalent labels for the Pfizer vaccine have identical cap and label colors. For Moderna, the bivalent vaccine will be distinct from the adult monovalent dose, but may look similar to the product for ages 6 through 11. Next slide. And for the equity question for this domain, is it feasible to implement across all population? Next slide. Again, we've looked at data from the data tracker demonstrating persistent racial and ethnic disparities in receipt of the first booster among those who are eligible. We previously reviewed the survey data demonstrating that about a third of adults of Hispanic or Latino ethnicity had completed a primary series but not received a booster. Here in the data tracker, we see that those 12 and up who are eligible for a first booster, over half of those of Hispanic or Latino ethnicity had not received it. And in fact, more than half of eligible populations of many populations, the American Indian Alaskan Native, Black, Native Hawaiian, and Pacific Islander populations have also not received their first booster. Next slide. In summary, use of the bivalent COVID vaccines appears feasible, but with some important limitations. Over 200 million people will be eligible for these bivalent vaccines. Most are at least 6 months out from their last COVID vaccine dose. CDC has provided an operational planning guide for jurisdictions' preparation, and has noted there will be a sufficient but finite supply of these bivalent vaccines. Some aspects of these vaccines will be easy for implementation, but vials and labeling may require additional education. And importantly, significant racial and ethnic disparities persist in receipt of a booster, suggesting that the intervention may not be equally feasible to implement across all populations. Next slide. So the work group felt the feasibility that it was probably yes, feasible to implement. Next slide. Moving to resource use. Next slide. This study is a preprint, and it evaluated COVID attributable disease and direct medical costs that could be averted by a booster program under two potential scenarios. On the left is with coverage similar to influenza vaccination rates, and on the right is if we achieved broader coverage of 80%. They estimate that an early fall booster vaccination program that reaches coverage similar to the 2020-2021 influenza season could prevent up to $62 billion in direct medical costs, and this would further increase with broader coverage of the vaccines. Next slide. So this shows that data in a graphical format, showing the cost comparing the cost that could be saved compared to their estimate of the vaccination cost. Note this isn't a peer-reviewed publication quite yet or a model that CDC has conducted, but it includes data of possible estimates of a cost-benefit scenario using their model estimates. Next slide. Then for the equity question for this domain, is the intervention a reasonable and efficient allocation of resources across all populations? Next slide. Note that cost-effectiveness data are not yet available for most demographic subgroups, but there is one study that was available for older adults. Looked at the cost-effectiveness of the first booster dose of the Pfizer BioNTech vaccine administered 6 months after the second dose among adults 65 and over from a healthcare system perspective. Compared to a 2-dose primary series but without a booster, the booster strategy and 100,000 older adults resulted in a net monetary benefit of over $3 million and a 3.7 quality adjusted life years over 180 days. Noting that the cost effectiveness of the boosters is highly sensitive to the population incidence of COVID and the vaccine effectiveness, the study estimated that offering COVID boosters to adults 65 and over in the US was likely to be cost effective. Next slide. So overall, a fall vaccination campaign that expands eligibility for booster and moves to reach people could avert a surge of hospitalizations and deaths that would result in substantial savings in direct medical costs. Next slide. So the work group felt that the bivalent vaccines probably, yes, were an efficient and reasonable and efficient allocation of resources. Next slide. In summary, next slide. So this slide looks like a lot, but I'm just trying to walk through the compositions of the updated or bivalent vaccines on the right compared to the current or monovalent vaccines on the left. For the current Moderna vaccine, there's 50 micrograms of the ancestral strain. For the current monovalent Pfizer vaccine, there's 30 micrograms of the ancestral strain. Then on the right, the updated or bivalent Moderna vaccine contains 25 micrograms of the ancestral strain and 25 micrograms of the spike protein from Omicron BA.4/5. For Pfizer, it's 15 micrograms of ancestral and 15 micrograms of BA.4/5. But note that overall, the bivalent vaccines have the same total antigen amount as the monovalent vaccines, just with the additional Omicron composition. Next slide. So the summary of the data that was presented in ETR show that the current monovalent COVID vaccines have dramatically reduced COVID hospitalizations and deaths. However, we know that as the virus has evolved, declines in neutralizing antibodies and declines in vaccine effectiveness have been noted, as well as more rapid waning from the vaccines. Inclusion of a second SARS-CoV-2 variant in the vaccine broadens the antibody response. Omicron-specific bivalent vaccines were studied in over 1,400 individuals. An Omicron-specific bivalent vaccine resulted in higher antibody titers for Omicron variants, higher titers for other SARS-CoV-2 variants, and titers that were as high or higher for ancestral SARS-CoV-2. And we know that broad uptake of COVID vaccine booster doses early this fall could prevent over 100,000 hospitalizations compared to a later or more limited rollout, and may even save billions of dollars of direct medical costs. Next slide. So to avoid, I know that was a lot, what we're going to do right now is walk through, I've finished the evidence to recommendation framework, the data. So congratulations, we made it to the end of that. We'll break it up just a little bit. So right now we're going to break for clarifying questions on data presented to ETR. Then I will turn it over to Dr. Hall and Dr. Twentyman as they walk us through the clinical considerations for the bivalent vaccines if ACIP votes to recommend them today. After that, we'll break for clarifying questions on the clinical considerations. Then you'll get me back for an encore, discussing the overall workgroup interpretation of the data, and we'll open it up for discussion of possible recommendations. So with that, I'll turn it over to Dr. Lee for clarifying questions on ETR. Thanks.
Thank you, Dr. Oliver. That was terrific, and we really appreciate the break and the ability to ask some questions. So I'll open it up to my colleagues to see if there are any questions about the ETR domains. Ms. McNally.
Thank you, Dr. Oliver, for a really informative presentation. I'm going to state in advance that I don't know if this question is more appropriate here or for the workgroup interpretation, but I would like to try and see if anyone can answer the question of whether the strain alteration change, whether it changes the vaccine safety risk-benefit analysis.
Yeah, thanks. I'm happy to kind of summarize the current understanding. So as we walked through the differences between, so we have extensive safety data on overall the mRNA platform and use of the monovalent mRNA vaccines. Then we have safety data from over 1,400 individuals who received a bivalent Omicron vaccine, and there were no safety concerns raised there. We know that the differences between BA.1 and BA.4/5 are enough to impact some of the antibody titers, which is why FDA chose to ask for the BA.4/5 vaccine. But we do not anticipate that those amino acid substitutions would overall change the safety or overall benefit risk balance. What we do know is we don't know the incremental benefits that would be going from the BA.1 to the BA.4/5. But given the experience, the experts that have weighed in on this, we do not anticipate that the safety or reactogenicity of the vaccines would be different with the BA.1 vaccine versus the BA.4/5 containing vaccine. Thanks.
Thank you.
Thank you. Dr. Palin?
I too want to say thank you for presenting so much information clearly, and I really appreciated how equity was reviewed with each part of the domains and thought that was highly effective. Can you go back to the area where we were looking at modeling, and we had two different approaches, and I just need to, if you could help me review that data, it would be really helpful. Thank you.
Absolutely. I know it goes by fast. I will also say, I'll walk through a little bit, and then we have some of our individuals who actually did the modeling. So I'll see if they have anything else to add. So there have been many rounds as the virus has evolved. There was round 14 that kind of looks like a 2x2 table. So they looked at, for vaccines, if we went with 50 and over only or 18 and over. Then they also looked at no new variants or kind of a new variant, and those 4 possible permutations. Then round 15 said, we're going to have the same no variant versus variant, but the vaccine assumptions are going to change. Instead of going with age, we're going to look at time. So we're going to assume everyone 18 and over is recommended, but what if we went from rolling it out in September versus rolling it out in November? Then next slide. This, as you can see, there's kind of the 4 boxes. So there's the 4 permutations, and we're highlighting what would kind of the most relevant here, which was while we may not be able to control the variant, we could control the age of the vaccine recommendations. And so a broader uptake leads to more hospitalizations and deaths averted. Then I'll go ahead and just go to slide 15. I may turn it over to Dr. Lessler if you would like to, but one more slide. Oh, sorry, just round 15. And then this also shows that in round 15, yes. That this was then again looking at kind of the early rolling out vaccine in September versus rolling it out in November. And we saw that there was more hospitalizations and deaths that could be averted by early rollout. But that is a way oversimplification. So I'll see Dr. Wallace and Dr. Lessler are on. So I'll turn it over to them if they want to explain further. Justin, are you?
Yeah, I'm here. Can you hear me?
We can.
So I think that was a good summary. Round 14, ignoring the potential impact of a new variant, round 14 was really looking at this contrast between something that looked like earlier booster rounds versus this idea that we could achieve annual flu-like vaccine coverage in those 18 and older. And we did find this, project a substantial impact of that in that round. Now that round was done in early June. So, or based on data up to early June. So the amount of data we had there about exactly what the impact of BA.5 would be and how things might progress as we entered the fall was less than the second round. So there is a change between the 2 rounds, both in exactly how much data we have and in in what we're looking at. So going on to round 15. Round 15 was really a kind of a redux of round 14 with the idea of we're going to do everything the same, except we're going to look at, based on input from a variety of folks, we're going to like zero in on this 18 or older flu-like uptake scenario and see how big an impact timing has. Is September, a September flu-like campaign prevent more deaths and hospitalizations than a November one? And we did see, as shown here, an impact of that. But that's not the only difference, because of course here we have a lot more data to fit. So you'll notice these confidence intervals, and to explain these figures, the darkest is a 50% projection interval, the next darkest is an 80% projection interval, the next darkest is 90, and the next darkest is 95. You'll notice those have gotten narrower, which is largely because we have more data at this point. So hopefully that's clarifying.
Thank you. Dr. Long?
It's about the same thing, but I don't know that it would be helpful for me to understand rounds. Or exactly what we're looking at, 552, means. It would look like you anticipate in January of 2023 we're going to have a whole lot of cases. Is that what that looks like?
So that right column is under the assumption of a hypothetical immune escape variant, what we call variant.
I see.
So the variant X starts entering the country in the late fall. It has the variant, that variant is assumed to have 40% immune escape, including to the vaccine. So of course we see some probability of a big wave there. The left side is the no new variant scenario.
I see. And what I'm trying to understand is this advantage of September, because you think making it an influenza-like recommendation in September will immunize more people, or because you think that the Omicron 4-5 going on right now is still robust enough to get a lot of people sick and dead or in the hospital?
It's that second. It's the
second.
Yeah. So in the two scenarios, we're assuming the exact same uptake. So the exact same number of people get them in round 15. And this is for round 15. So in round 15, we're assuming the exact same uptake in the early, what we're calling the early booster and the late booster scenarios. It's just the timing that's different.
And it's because there's still Omicron going on now.
Yeah, and some of the models, if not most of the models, assume that, absent a booster, seasonal effects and immunological waning could allow additional cases to occur in the fall, particularly, potentially a reasonably high number of them.
So that was my last question. In this model, you assumed no early waning.
So,
like 3 months, 4 months.
So,
because what if it looks as if Omicron is falling. And what if we did transition to a seasonal or a new variant in January, and the vaccine immunity only lasts for 3 months, 4 months? That would be a bad choice.
Right. So I can dig into that a little bit. That is something that came up, and so one thing I'd say is, it's important to remember about the Scenario Modeling Hub is this is a multi-team effort. So we're really bringing together information from in this case at the national level, 5 different teams. So we have more teams at the various state levels. All of those teams had to have some level of immune waning in their model, but they were free to, within certain parameters, have the speed of that immune waning be based upon their best interpretation of past data. So some teams had relatively rapid immunological waning that was closer to the 3 to 4 month range, and some had longer waning. you do see in a couple of scenarios that, for a couple of the models, that because of that, you do see exactly the phenomena that you're saying, that that you see a little bit more hospitalization in the early booster scenario than the late booster scenario in that later wave. But for any of the models, but overall, the majority of the models did not show that, and even those that did, it tended to be offset by the benefit you get from the earlier boosting overall. So that's all to say. This was something that was covered by the space of models. The effect you're saying does exist to some extent, but because we're not waning, I think partially because we're not waning to zero, the net effect being projected by most of the models was still more benefited earlier boosters versus later, even with that effect in there.
Thank you so much. Very helpful.
Thank you. Dr. Sanchez, last question, and then we'll move to the next section.
Sure. Thank you. First of all, I just want to make a comment, I think on your slide 80, just to defend my Hispanic heritage. When you said that, when you comment about a third of adults of Hispanic Latino ethnicity, and I'm glad you say Latino, not Latinx, say they're fully vaccinated for COVID-19 but haven't received their booster yet. Actually, I think by current definition, they are fully vaccinated. They are correct, but they may not be up to date. That's just a minor comment. I'm just, struggling with a recommendation. I understand that we need better vaccines, whether it's a messenger RNA, whether it's some other platform, but we need better vaccines because obviously we're still, we're still having a lot of COVID despite vaccination. Even though it has been extremely helpful and protection against severe disease, there's no question about it. But I'm struggling with making a recommendation for a vaccine, bivalent vaccine, and I fully support the need for such. But to make a recommendation for a vaccine that has not been studied in humans, and at least that I'm not seeing the data. I know there's ongoing studies. We're going to make a recommendation for 18 and over, and then the other one, I'm just very, I just want to bring that up. That yes, bivalent vaccine, the BA1 has been studied, but that's not the vaccine we're going to be recommending. And so I just want to bring that up as a concern. And I guess I'll stop there.
Thank you, Dr. Sanchez. Dr. Daly, really last comment.
Okay, well, I think I would like to then either now or later come back to the sort of fundamental point that Dr. Sanchez is raising, but we can also do that after ICC if you feel like that would work, after clinical considerations if you feel like it's a better time.
I think it's okay to address now. We're going to get back to this when we get to the full discussion. I think this is actually, but it feels like that would be for the last section after clinical considerations, and maybe we can talk about that together as a group. So I imagine there's multiple individuals that have diverse opinions on this. So
okay, let's do that. Okay, I'll put my hand down. Yeah, thanks.
Thank you. So let's move on to clinical considerations at this point. Dr. Hall, would you be able to put up your slides and lead us through?
All right, thank you. So I'll be sharing anticipated updates to the interim clinical considerations for COVID-19 vaccines contingent on a recommendation for these vaccines. Next slide. So yesterday, Moderna and Pfizer bivalent vaccines were authorized. Moderna for use in people ages 18 years and older, and Pfizer for use in people ages 12 years and older. These vaccines were authorized for use as a single booster dose administered at least 2 months after either completion of primary vaccination with any authorized or approved monovalent COVID-19 vaccine, or receipt of the most recent booster dose with any authorized or approved monovalent COVID-19 vaccine. Next slide. Along with the authorization of bivalent vaccines for ages 12 years and older for the booster, monovalent mRNA COVID-19 vaccines are no longer authorized as booster doses for individuals ages 12 years and older. This means that monovalent booster doses can no longer be given to people ages 12 years and older, even if the person had not previously received a monovalent booster dose. Next slide. So with this new authorization for an updated bivalent booster, at a high level, everyone ages 12 years and older is recommended to receive one age-appropriate bivalent mRNA booster dose after completion of any FDA-approved or authorized monovalent primary series or last monovalent booster dose. So this means people cannot get a bivalent booster without first completing a primary series. Homologous and heterologous boosters are allowed as long as they are age-appropriate, meaning only Pfizer bivalent can be given to people ages 12 through 17, but either Moderna or Pfizer bivalent can be given to people ages 18 years and older. There is no preference. At this time, there are no changes to schedules for children ages 6 months through 11 years. Next slide. So again, the bivalent booster recommendation replaces previous booster recommendations for people ages 12 years and older. This means that now everyone ages 5 years and older who are eligible for a booster dose are only eligible for one booster dose. People ages 5 through 11 who received Pfizer are eligible for the one monovalent booster dose currently, and people 12 years and older, one bivalent booster dose. Next slide. If you perceive this as a big change to dose counting, you're right, our recommendations are simplified. We are changing the way we're thinking about these vaccines from dose counting monovalent boosters to one bivalent booster for everyone eligible. So this table just reinforces that regardless of whether you've had 0, 1, or 2 monovalent boosters, one bivalent booster is now recommended next. So since some people may have already had 3, 4, or even 5 doses for those who are immunocompromised and had a second booster already, we want to emphasize we're no longer looking at total number of doses. If eligible, meaning age 12 and older, have completed at least a primary series, and are 2 months out from the last dose, a bivalent booster should not be denied based on the number of total doses the person has received. Next slide. Shown on this slide is a visual of what the revised schedule for people who are not moderately or severely immunocompromised would look like. The schedule is going to look a bit different as it has been significantly simplified. So starting at this top row for people ages 12 years and older, you're recommended to receive a primary series, either Moderna, Novavax, or Pfizer is recommended, and then this would be followed by an age-appropriate bivalent booster dose at least 2 months or 8 weeks after completion of the primary series or most recent monovalent booster. As shown in this arrow, the bivalent booster is now recommended regardless of how many previous monovalent boosters were received. In certain limited situations, Janssen can be used, followed by a bivalent booster at least 2 months later. Next slide. Now looking at the schedule for people who are moderately or severely immunocompromised, the primary series is not changing. This remains the same. Again, Moderna, Novavax, or Pfizer are recommended. So for Moderna and Pfizer, this is 3 doses. For Novavax, this is 2, and the bivalent recommendation is the same for everyone, one bivalent booster dose at least 2 months after completion of the primary series or most recent previous monovalent booster dose. Again, Janssen is only used in limited situations for those 18 years and older. Those who got a Janssen primary dose get an additional mRNA followed by a bivalent booster. Now I'll hand it over to Dr. Twentyman to talk more about supplementing the schedule for people who are immunocompromised with Evusheld.
Thank you so much, Dr. Hall. This simplification of recommendations is a great opportunity to look closely at the spectrum of resources we have available to protect people with moderate to severe immunocompromise. Therefore, in addition to the potential new recommendation to receive an updated bivalent booster we're discussing today, let's also look at existing recommendations for pre-exposure prophylaxis, which can be used in complement to our COVID-19 vaccines to protect our immunocompromised population. Next slide, please. Pre-exposure prophylaxis refers to a medication that is given before exposure to an infectious disease to protect an individual against that disease. The pre-exposure prophylaxis Evusheld is recommended for those ages 12 and up who weigh at least 40 kilograms or 88 pounds with moderate to severe immunocompromise due to a medical condition or receipt of certain immunosuppressing treatments. Examples of such medical conditions or treatments are included in the Evusheld emergency use authorization fact sheets on CDC's website and are similar to those previously leading to eligibility for multiple boosters. Evusheld is also recommended to be given to those who are unable to receive COVID-19 vaccine due to a history of severe adverse reaction to a COVID-19 vaccine or one of its components. Next slide, please. Tixagevimab and silgavimab, or Evusheld, is a combination of two long-acting human monoclonal antibodies derived from B cells donated by convalescent patients after SARS-CoV-2 infection. The FDA issued an emergency use authorization for use of Evusheld for pre-exposure prophylaxis in December of 21, revised the EUA to increase the dose to 300 milligrams of each monoclonal antibody in February of 2022, and revised the fact sheet for healthcare providers to recommend Evusheld be administered every 6 months in June of 2022. Evusheld must be prescribed by a healthcare provider. Doses can be found through the U.S. government therapeutic locator tool on ASPR's website, linked here. As of last month, there is also a new ordering pathway available through the HHS Health Partner Order Portal, or HPOP, such that in addition to the large orders available through the HPOP distribution process, providers who aren't participating in that process can now order up to 3 doses through the small volume orders portal linked here. Next slide, please. Use of Evusheld is evidence-based. In a randomized clinical trial, Evusheld had efficacy for the prevention of COVID-19, and in multiple other studies, including real-world data, Evusheld was observed to have efficacy against severe COVID-19 outcomes, including during this period of Omicron variant predominance. Additionally, in vitro studies show that Evusheld is predicted to work against BA.4/5. Next slide, please. Despite the protection that Evusheld can provide, most people with immunocompromise in the U.S. have not actually received Evusheld. Among the almost 7 million individuals with immunocompromise, a very small percentage, or about 5%, have actually received doses of Evusheld. This is not an issue of supply. Current Evusheld supply far exceeds demand, and more than 390,000 doses are already distributed and available for use today. Evusheld is distributed by the U.S. government at no cost to participants, although some locations of administration may have an associated administration fee. Next slide, please. Here, we illustrate how use of monoclonal antibodies for pre-exposure prophylaxis can complement receipt of COVID-19 vaccines for optimal protection of those with immunocompromise. Specifically, after any dose of COVID-19 vaccine, an individual should wait 2 weeks before receiving Evusheld. After Evusheld, there is no minimum interval to the next COVID-19 vaccine, either within a primary series or if receiving a booster dose. Evusheld is recommended to be administered every 6 months, and individuals should consult with their physician for a prescription. Next slide, please. CDC is in the process of updating several web pages to make this information more widely available. Updated content for healthcare providers will include descriptions of patient eligibility and detailed Evusheld administration guidance, as well as those links to options for ordering Evusheld as were shown earlier. Updated content for the general public will include additional information about how to know if you're eligible for Evusheld, as well as the dose finder shown earlier. Updated language within our interim clinical considerations for use of authorized and approved COVID-19 vaccines will clearly describe how use of Evusheld complements COVID-19 vaccination to optimally protect people with moderate to severe immunocompromise. Thanks very much, and back to you, Dr. Hall.
Thank you, Dr. Twentyman. Next slide, please. Now I'll dive into specifics on timing considerations for bivalent boosters. Next slide. Our current timing guidance for vaccination in persons with current or prior SARS-CoV-2 infection also applies to bivalent boosters. If a person has current or prior SARS-CoV-2 infection, at a minimum, vaccination should be deferred at least until recovery from acute illness and criteria to discontinue isolation have been met. This is the minimum. Additionally, these people may consider delaying vaccination longer, by 3 months from symptom onset or positive test if infection was asymptomatic. Individual factors such as risk of COVID-19 severe disease, community level, or characteristics of the predominant strain should be taken into account when determining whether to delay getting a COVID-19 vaccine after infection. Next slide. With new bivalent vaccines, co-administration guidance has not changed. Routine administration of all age-appropriate doses of vaccines simultaneously is recommended as best practice for people for whom no specific contraindications exist at the time of the healthcare visit. I'll note that orthopox virus vaccine does not follow the same routine guidance, and further information on that very specific situation can be found in CDC's interim clinical considerations. Extensive experience with non-COVID-19 vaccines has demonstrated that immunogenicity and adverse event profiles are generally similar when vaccines are administered simultaneously as when they are administered alone. Therefore, providers should offer all vaccines for which a person is eligible at the same visit. Next slide. With both influenza and COVID-19 vaccine campaigns, we've received a lot of questions about co-administration of these vaccines specifically. Providers should offer influenza and COVID-19 vaccines at the same visit if eligible. This includes adjuvanted or high-dose influenza vaccines, but the recommendation in this case is to administer in separate limbs. With both influenza and SARS-CoV-2 circulating, getting both vaccines is important for prevention of severe disease, hospitalization, and death. Getting both vaccines at the same visit increases the chance that a person will be up to date with their vaccinations. Next slide. Studies looking at co-administration have shown that immunogenicity is similar between those who received co-administered COVID-19 vaccine and seasonal influenza vaccine and those who received these vaccines separately. We know many people have received simultaneous vaccination with influenza vaccine last season. 9.4% of VSafe participants reported simultaneous vaccination with an mRNA COVID-19 vaccine and seasonal influenza vaccine. 8.7% of persons enrolled in the Vaccine Safety Data Link received simultaneous vaccination with a COVID-19 booster and seasonal influenza vaccine during the 21-22 influenza season. Next slide. Finally, this slide summarizes studies to date on reactogenicity of co-administered COVID-19 vaccine and seasonal influenza vaccine. This chart shows the percent difference in participants reporting reactogenicity between COVID-19 and influenza vaccine versus COVID-19 alone. On the left axis is listed which vaccines were co-administered, including any seasonal influenza vaccine, adjuvanted, cell-based, recombinant, and high-dose influenza vaccines. In the chart, systemic reactions are shown in green and local in blue. To the left of the 0 are the differences in which more reactogenicity was observed with COVID-19 vaccines alone, and to the right are differences in which more reactogenicity was observed with COVID-19 and influenza vaccine co-administration. Generally, COVID-19 vaccines administered with seasonal influenza vaccine showed similar or only slightly higher reactogenicity, and no specific safety concerns were identified. Next slide. And this just states the conclusion I just mentioned. Next slide. So in terms of best practices for multiple injections, we recommend to label each syringe with the name and dosage of the vaccine, lot number, initials of preparer, and beyond use time if applicable. Administer each vaccine in a different injection site and separate injection sites by 1 inch or more. And finally, administer the COVID-19 vaccine and vaccines that may be more likely to cause a local reaction in different limbs if possible. I mentioned this earlier. An example would be adjuvanted or high-dose influenza vaccine and COVID-19 vaccines. Next slide. Now take a look at the bivalent vaccine products in comparison to the current monovalent products. Starting with Pfizer, monovalent and bivalent cap and border label colors will be identical. They are both gray. Most characteristics are the same, authorized for 12 years and older, 30 micrograms. The injection volume is 0.3 milliliters. Dilution is not required for these specific products, although other Pfizer products require dilution. And they have the same beyond use of 12 hours and the same storage. The differences shaded in gray on this chart are the composition, monovalent and bivalent, and the type of dose. The monovalent is primary series, and the bivalent is booster doses. Next slide. Can you go back one slide? So here are the labels. So on the left is the monovalent, on the right is the bivalent. They are almost identical, aside from on the right in the red box, the name is different, and that is about it. So this is something to be aware of for errors. We're going to be having education on strategies to prevent admin errors so that we can try to reduce these errors in provider offices. Next slide. So for Moderna, I'll highlight 2 different vials in comparison to the bivalent. The one for the older age group, ages 12 years and older, and then the one with the most similar appearance, and that's actually for ages 6 through 11. Next slide. So first, the monovalent product authorized for ages 12 years and older is fairly visually distinct from the bivalent product authorized for ages 18 years and older. The monovalent is in a red capped vial with a light blue label border color, and this is now only authorized for primary doses. Comparatively, the bivalent product for booster doses in people 18 years and older is in a vial with a dark blue cap and a gray label border. Again, the injection volume is the same beyond use date of 12 hours, and the same storage. Next slide. So here are the labels of the 2 products I just highlighted. As you can see, they're much more visually distinct. The bivalent booster is clearly labeled booster doses only in all caps, and there are different colors on these labels. Next slide. So the vial that looks the most similar is actually the monovalent product authorized for primary doses in people ages 6 through 11 years. This vial also uses a dark blue cap, and the visual distinction is the purple label border. Next slide. Here's a look at the label comparing. So both say booster doses only in all caps. However, of note, the monovalent vial authorized for primary doses in ages 6 through 11 is not authorized for booster doses. The main distinction is the name of the vaccine and the color of the border and the background for the booster doses only text, purple versus gray. So this is also something to keep an eye out for and implement strategies to prevent errors. Next slide. And finally, CDC continues to encourage people to stay up to date with their COVID-19 vaccines. Staying up to date keeps people current with the COVID-19 vaccine recommendations. With new recommendations, people are up to date if they have completed a primary series and received the most recent booster dose recommended for them by CDC. Next slide. And now we'll break for questions.
Thank you, Dr. Hall. Ms. McNally.
Thank you. I'm thinking about recent infections, and I just want to clarify whether there is data to answer the question of whether prior recent infection plus vaccination with the bivalent vaccine has any indication of increased myocarditis. Thank you.
Alicia, this is Tom. Do you want me to take that one?
Sure. I was going to say no, but I did not have a more detailed answer.
Yeah, I mean, I don't think we have any information on the bivalent booster dose, but we do know that individuals who have a recent COVID infection and then are vaccinated for COVID can experience increased reactogenicity events, but we don't have any evidence that places them at increased risk for myocarditis.
Okay, Dr. Shimabukuro, can you clarify whether we're talking about a time frame that is less than 90 days or more like recent infection just after 90 days when you say that?
I don't have the exact time frame off the top of my head, but there's actually a couple of studies which aren't published yet. One looks in VSafe data, and it looks at people who report having a vaccination, and I'm not sure how they define it, but I suspect it's on the order of within several months. But based on that information, self-reported reactogenicity appears to be, and that's things like systemic reactogenicity, fever, fatigue, muscle aches, that type of thing, is reported with higher frequency if you've had a recent infection. But again, there's no evidence, or there's a lack of evidence that places you at increased risk for myocarditis.
Okay, that's helpful. I have one follow-up question since we have you. Can you confirm for us that the CDC and the work group, and whether that's VAST or the COVID work group, will be following the international safety data for this particular vaccine?
I would defer to maybe Dr. Oliver about the U.S. vaccines versus the international new booster vaccinations. I'm not sure about the formulations for those, but I will say that we regularly consult with our public health and regulatory colleagues, international colleagues, to exchange information and to better keep on top of the safety data. So the answer is yes.
Yeah, and I'm happy. This is Sarah for the COVID work group as well. Yes, we will collaborate. There are NITAGs, which is the things like ACIP that are across the globe, and with other safety agencies to look at any available safety data for bivalent vaccines, whether it's the BA1 vaccine that's used in some countries in Europe and potentially Canada, as well as the BA4/5 vaccine if that's used internationally as well. Yeah, thanks.
Thank you.
Thank you. And we have Dr. Deeks on. If she wants to raise her hand later and make any comments, that would be great. I don't want to put her on the spot in the moment. We'll move to Dr. Paling.
Thank you. My big question, and I'm going to outline it a little bit more before I ask it, is really about the switch immediately from bivalent to monovalent boosters. And here's the thought process behind my question so that we can have a robust discussion. The data reviewed today highlight great benefits of booster dose on preventing hospitalization and death, and this data includes the monovalent vaccine. We have also reviewed and discussed disparities. In this discussion, we noted that factors like access may contribute to those disparities. It was implied in the discussion that there will be sufficient supply to replace monovalent with bivalent booster dose. My concern is that this information differs what we're receiving locally, that our initial supply will be small. And so could you please clarify what the anticipated supply distribution is and how we can make sure not to exacerbate disparities? Thank you.
Hi, this is Sarah Meyer. So thank you for that comment. I guess what I'd like to say is, we've been working through all of our established channels for making sure that this bivalent booster vaccine is accessible nationwide. We have hundreds of thousands of doses being delivered around the country today. And by the end of the holiday weekend, millions of doses will be in the field, with more arriving every day. So we anticipate that we will, quickly be able to have, an authorized available booster product out there over the next couple of days. But then to your longer term question about how can we make sure that we have, sufficient supply access and ensuring equity, we will be distributing this vaccine to tens of thousands of sites across the country. The vast majority of people will be within a 5-mile radius of a COVID-19 vaccine site. And we've been working for years now to make sure that we have equitable access, including efforts to make sure the vaccine is available for high-risk populations, including long-term care facility residents, and also in areas that serve people who may be at higher risk because of their race or ethnicity and underlying conditions. We've been working with many partners for years now to build those networks to ensure that we can continue to have equitable access for this vaccine. So I hope that helps to answer the question.
It does, except I worry about our children because the vast majority of children get vaccinated in the primary care setting. And I hope that has been an important component of what has been included in this thought process. Thank you.
Thank you. I see Dr. Deeks has raised her hand. Oh, sorry. Go ahead, Dr. Meyer. Did you want to add any additional comments?
Well, no, I don't need to, but I was just going to acknowledge that comment and just say that, yes, and as we think about bivalent booster authorizations potentially in the future moving down in the age groups, we'll continue to rely on our strong network of providers. Again, most VFC, a large number of VFC providers also participate in the COVID-19 program. We do have a pretty robust network of pediatric providers that are participating, and we would anticipate continuing to leverage all these partnerships for pediatric vaccines as well.
Yeah, just sorry to jump in, but just to augment that issue. I mean, this is why I've been so worried about the labeling issue, because it's impairing our ability to actually deliver vaccines without fear of causing any adverse events. So we are, kind of partitioning out sort of the way we think about these doses in order to make sure we give it in the safest and most reliable way. But it would just be a lot easier if some of these labeling issues got fixed, to be honest. Dr. Deeks.
Okay, thank you very much. Yeah, we had licensed the bivalent, Moderna bivalent, BA1 was licensed today in Canada, and NACI recommendations were also released today. Similar to the US, we are approaching the fall booster as a fall booster and stopping dose counting. So recommending that individuals receive a fall booster regardless of previous number of booster doses. Unlike the US, our ancestral products remain licensed. And because there is a concern of potential supply, and at least initially, our recommendations were that an authorized dose of a bivalent vaccine should be offered as a booster dose, but if the bivalent Omicron-containing vaccine isn't readily available, an original or ancestral vaccine should be offered. And then our timing is a recommendation for 6 months, as opposed to, I think, what you're talking about, which is 2 months. But noting that it can be decreased to a minimum of 3 months if epidemiologic conditions warrant it. And then we have given an off-label. NACI does a lot of off-label recommendations, so we have given an off-label recommendation for bivalent Moderna for adolescents 12 to 17 years of age, but only those adolescents with moderately to severely immunocompromising conditions or who have a biologic or social risk factor that puts them at place of high risk for severe outcomes, given that there are no data for Moderna in this age group. So it was only authorized in Canada, as I said, to 18. Pfizer is not yet authorized, so we don't have NACI recommendations for them. Thanks, Grace.
Yeah, no, thank you very much. And, Dr. Deeks is my counterpart in Canada, so just for clarification. Ms. Bata.
Thank you. I think I need a little clarification. When you had been going through the scenarios for bivalent versus monovalent for kids versus adults, and my question is, right now the one monovalent booster is recommended. Now, are we assuming that will change once we have an authorized product, a bivalent product?
And so right now, the only monovalent that can be used for a booster dose is the Pfizer product for people ages 5 through 11 years who received a Pfizer primary series. That's essentially the only small population that the monovalent booster dose would still be recommended in. And we would anticipate to respond when and if FDA authorizes a bivalent for the younger age group to then make applicable recommendations afterwards.
Thank you, Dr. Hall.
Thank you. Dr. Saneas?
Thank you. I share the concerns of Dr. Lee regarding the labeling of these vaccines. And given that the Pfizer monovalent and bivalent look very similar, in fact, in our system, the monovalent is to be ordered in EPIC as the gray cap, and now we'll have 2 gray caps. What happens, or what is the clinical recommendation when a patient receives inadvertently a bivalent vaccine instead of a monovalent as part of their primary series? What will be the guidance on that? Because I do see this scenario happening.
So I'm going to do both scenarios just in case. So if for the Pfizer gray label, if a monovalent is administered instead of a bivalent for the booster, in general, the recommendation is going to be do not repeat the dose. Vice versa, if a bivalent is administered instead of a monovalent for a primary dose, again, we're going to say do not repeat the dose.
Thank you.
Thank you. Dr. Cotton.
Thank you very much for your emphasis on encouraging Evusheld. I think it's a really important option, especially for the most immunocompromised and most vulnerable. Could I ask you to comment on, there's a lot of confusion and a lot of people are making up rules about when they should get vaccine and when they should be getting Evusheld. And it's pretty clear in the Evusheld EUA that people should not get vaccines for 2 weeks afterwards. But can you comment, you or anyone else on the call comment as to whether there's actually an immunologic impact by getting Evusheld as far as decreasing response to vaccination. And maybe you could go back to the Evusheld slides and just put up the interval recommendation.
Slide 129, please. Thank you so much, Dr. Cotton. There it is. Excellent. So to review the schedule, it is true that by Evusheld EUA, emergency use authorization, Evusheld needs to be given at least 2 weeks after any dose of any COVID-19 vaccine. However, after Evusheld, there is no minimum interval to the next COVID-19 vaccine. And we did want to underscore that today because you may be quite correct that there is a misunderstanding of in which direction that 2 weeks works. I hope that is helpful. Thank you.
Yes. Thanks very much for providing the clarity here.
Thank you. Dr. Bell?
Thank you. I likely missed this, but could you review what the clinical considerations are going to say about the interval between the last dose and the booster dose, not for people who were known to previously have COVID? Is it saying 2 months? Is it saying at least 2 months? How are you going to deal with that?
Okay, so for people who did not have a recent infection, I think, if I'm understanding you correctly, from the last dose, the interval is going to align with the EUA, which is at least 2 months.
Okay, that was my question. And has anybody been giving any thought to providing any additional data around that with respect to the effectiveness of the booster dose with a longer interval, other considerations, anything like that? Are you planning to add any additional verbiage, or are you just planning to leave it like that? As you can tell, I feel a little bit, I think it would be unfortunate if people interpreted the 2 months, at least 2 months, as 2 months, since it seems to me there's at least some suggestion that waiting is perhaps would improve performance of the vaccine.
Yeah, thanks, Dr. Bell. Since this is more around kind of the authorization and the vote. So, I mean, I think the EUA, what is kind of authorized is this at least 2 months. There was slides in slide that did kind of break down where people were. So you can see that for most of the population, less than 50 years of age, it has nearly all of that population less than 50 years has been at least 6 months since their last vaccine dose. So I think there's both the kind of what is the earliest interval legally allowed by the authorization. And I think, it would be important that we'll get into this as we kind of walk through what the votes may be, but that the CDC recommendations and ACIP recommendations mirror what is in the EUA. However, acknowledging that for most of these individuals, it's been at least 6 months since their last vaccine dose. We know that that's different for those 50 and over, where there are some individuals who have had a second booster in that kind of 6 month time frame. That's also the population that may be at the highest risk of severe outcome if they have a COVID infection. So I think the decision, there's the minimal interval that is authorized with the 2 months, and then I think the decision for when exactly to get this booster dose, and we can talk about this as we move into the recommendations as well, but can be informed by personal circumstances, when you've recently had COVID, when your last vaccine was, what your age and kind of individual risk factors for COVID are, and what your kind of upcoming risk activities may be if you're going to be, traveling or in a congregate setting in the future. So I think there's a lot of kind of personal experience that can go into when exactly it's given the dose. The legally, minimum interval is that 2 months, and then for the most of this population, 5 to 50 years, they're well beyond that, at least 6 months from their last dose.
Yeah, okay, thank you. I understand that from a practical perspective, this isn't really, it's not going to be a big problem for most people. And I also understand what the EUA says, but I do think it's something that'd be nice to at least provide some, as you say, some context for individuals.
Thank you. Dr. Lair.
Thank you for this wonderful presentation. I've got 2 comments. The first is an area for ongoing research. My awareness of immunocompromised people has been raised by Dr. Cotton, and I have been paying attention to the data which suggests that they are simply not responding to the doses well, and that they might need more than just 3 doses. And so I would encourage people to be aware of that this booster dose might be great, but it might not be enough for immunocompromised people, and we might have to revisit that down the road. My second comment is, it is incredibly confusing, and it took me literally 15 minutes while I was on this call trying to find comparisons of all the doses and vials and who can use it for what. And I would encourage that this somehow gets delineated with pictures for everybody so they can see what vial is being used for what situation. I finally found it on the CDC without pictures. It was pretty helpful, but I encourage possibly the CDC to put it out with pictures. Thank you.
And I'm not sure if the manufacturers are still here and can comment, but I believe there are some wall charts that have pictures on them that are available from those websites. And we just essentially did not recreate the wheel since they were already available. But if you're on the line to confirm if those have been updated for bivalence.
Dr. Lee just put a link in there, so I'll go looking some more on the internet and see what I can find. Thank you.
Yeah, sorry. I just, so folks know, the AAP has put out a really nice vaccine dosing quick reference guide after the last round of approvals for pediatric vaccines. I am hopeful that something similar could exist for this 12 and older population. Let's go to Dr. Sanchez. And then I see 4 additional hands raised. I'm just going to ask we go with quick questions and quick answers so that we can get to the additional discussion. This is only the clinical consideration section. Thank you.
One question. With Evusheld, has it been looked at for IV administration at all? I know the product that says IM, but I would imagine that question may come up.
Thank you, Dr. Sanchez. Do we have either of our representatives from the AstraZeneca sponsor on the phone, please?
This is Gavin Cole. Can you hear me?
Yes, we can. Thank you.
So Evusheld was studied intravenously in the first in human study. In the treatment studies in in Active 2 and Active 3, they were also studied IV, and the Active 3 data is currently published online.
So it can be done IV or IM. The picture just says IM.
It's not authorized for that use in the EUA, but the data exists in the Active 3 publication, which is in the public domain. The formulation that was used is not different.
Thank you. And another comment. Thank you on that. I really like the movement towards almost like a yearly booster type thing. I do like the despite my misgivings, as I've mentioned previously, I like the fact that we're moving towards just like a booster dose, and I think that's going to be helpful. I do want to echo Dr. Bell's comments though, because although most individuals who may be getting it soon, if it is approved or recommended, may already be 6 months out, we're going to be seeing people who may have only been a couple months out from their last one. And I do want to echo Dr. Bell's comments that it appears that waiting a little bit longer than that may improve the immunogenicity, plus have less potential for side effects, particularly cardiac. And I think that's all. Thank you.
Thank you, Dr. Sanchez. Ms. Roth?
Thank you. Representing AIM, I'll try and be fast. Back to the labeling, we're also concerned. Today was the first time I actually heard the rationale behind the why, right? Why they're labeled how they are. And I think sharing that more broadly with immunization programs and providers could help alleviate some of the frustration while we also tackle it from a training and education perspective. And then I'm wondering if you can speak to the expectations regarding providers having to document inadvertent monovalent boosters having been given since yesterday as vaccine administration in VAERS, and considerations for any increased wastage we might expect to see with that removal of authorization.
So that would be considered a reportable vaccine administration error. Tom, please correct me if I'm wrong, but I believe that would be a reportable vaccine administration error to VAERS.
What is the actual so what is the actual practice again? Can you just describe that?
If a monovalent,
somebody who oh, go ahead.
Yeah, if a monovalent was administered incorrectly, now that it's not authorized as a booster dose intended to be the bivalent, or vice versa, if the bivalent was administered as the primary series, which also it is not authorized for.
Yes, that would be a vaccination error, and I believe that's a vaccination errors are a reporting requirement.
Thank you, Dr. Hahn. And sorry, just for clarification, Dr. Shimabukuro, you mean reporting requirement to VAERS, correct?
Yes, to VAERS.
Okay, thank you. Dr. Hahn?
Yeah, thank you. Can you hear me okay?
We can, thank you.
Okay, great. Yeah, I just have a quick comment. State and local health departments are in the throes of putting on large monkeypox or orthopox virus vaccination clinics, targeting in many cases young males. Right now, the Jynneos vaccine clinical consideration says, and I quote, people, particularly adolescent or young adult males, might consider waiting 4 weeks after orthopox vaccination before receiving Moderna, Novavax, or Pfizer COVID vaccine because of concerns about myocarditis. I didn't hear, and I'm sorry if I missed it, but in the clinical considerations presentation, I didn't hear anything about monkeypox vaccines. And in light of the fact that we are trying to ramp up efforts, I would just ask that those recommendations be harmonized, make sure that the message is the same. We have a large one coming up, a large Pride event in a week, and I'm not sure right now. We're going to have people offering monkeypox, flu, and COVID, and now I'm not sure whether they should be doing them simultaneously. So if that could be addressed, I'd be very grateful.
Yes.
Thank you.
The COVID interim clinical considerations do match the monkeypox ones. Apologies, I did not highlight that specific situation on today's presentation, but it is in the text.
Thank you.
Thank you. Dr. Duchin?
Thank you. I would just like to remind folks that achieving optimal and equitable vaccination coverage requires more than just vaccination doses or vaccine doses. Your state and local health department colleagues are now in their third year, as well as our health clinicians are in the third year of COVID pandemic response, as well as trying to respond to monkeypox outbreak and vaccination campaigns on top of other local infectious disease outbreaks. Many areas are also grappling with climate-related health emergencies like heat, flooding, wildfires, and the work of achieving optimal vaccination coverage and equitable vaccination coverage requires significant investment in building relationships with community partners, empowering community partners, and developing trust. And that trust requires consistency. And that consistency and the adequacy of the response overall requires funding. We have not received additional COVID funding. We have not received any monkeypox funding. And we are very much running on fumes after such a long outbreak response that is being now multitasked with all the other overlaid responses by the same staff and healthcare providers. So I do want to put this information front and center for funding the necessary response at every level, not just the vaccine. Thank you.
Thank you, Dr. Duchin. Dr. Pilling, last quick question.
Yes, I'm still very concerned about, and this tag teams beautifully with Dr. Duchin's comment, that by saying we're going to do a massive switch on one day, and then if you inadvertently administer monovalent vaccine, which looks really similar to some of the others, now you have to need to submit a VAERS report. If we're trying to, the opportunity is to increase booster doses overall, and there's a huge opportunity. And it seems like we might be making this much harder than it should be. Thank you.
Thank you. Is it okay, Dr. Oliver, if we move on to your presentation? I'm happy to leave time for additional comments or responses, but perhaps at the end, if that's okay.
Absolutely. Okay. So just to summarize the overall workgroup interpretations, as Dr. Daly mentioned at the beginning of the day, the workgroup has met frequently over the course of the last several months to review data that would inform these recommendations. In addition, the workgroup has had broad policy discussions around the use of the updated bivalent COVID-19 vaccines for people in age groups currently recommended for booster doses. Again, as a reminder, based on the current FDA authorizations, the recommendations would be for the current recommendations would be for Pfizer BioNTech COVID-19 vaccine bivalent for individuals ages 12 years and over, and the Moderna vaccine bivalent for individuals 18 years and over. However, we expect that additional authorizations for other ages and vaccines may follow over the next several weeks to months. Next slide. The workgroup discussed that the current population recommended for these boosters is very heterogeneous. Many in the United States have had Omicron infection over the past 9 months. In addition, individuals recommended for the bivalent COVID-19 booster doses may have previously received a primary series only, one booster dose, or for the population 50 and over immunocompromised, 2 booster doses. The workgroup also noted that the balance of benefits and risks for individuals may vary by age, by previous receipt of booster, or by recent SARS-CoV-2 infection. And there are uncertainties around the incremental benefit for some individuals, including those with recent infection or recent vaccine receipt. Next slide. Then the workgroup also discussed recommendations in the setting of prior infection. We know overall that COVID-19 vaccines are recommended even for those who have had prior infection. We also know that the rates of reinfection increased during the Omicron period. Bivalent COVID-19 vaccines in the setting of prior SARS-CoV-2 infection, some of which called hybrid immunity, resulted in the highest antibody titers. And encouragingly, these high and diverse titers may result in a longer duration of protection and increased need for frequent COVID-19 vaccine booster doses. We also know that studies have shown that increased time between infection and vaccination may result in an improved immune response to vaccination. Those with recent SARS-CoV-2 infection may consider delaying the vaccine dose by 3 months from symptom onset or positive test. Next slide. Then the workgroup also discussed that time since most recent vaccine dose may be more important than total cumulative number of doses. We also fully acknowledge that there will be a time of transition as the recommendations move from counting dose number to optimal timing of the vaccination campaigns. And we very clearly know and have learned for the last 2 years that vaccine recommendations that are simple and easy to communicate are important. The workgroup also discussed that if SARS-CoV-2 becomes a seasonal virus, an annual vaccine program could be an effective strategy for the future. So all of this highlights that there's a distinct effort to simplify vaccine recommendations through a transition to what could be a more sustainable and long-term COVID vaccination program. Next slide. I also just briefly want to highlight the new framework for the equity data we use today. Next slide. And a key important part of the discussion through equity is that equity isn't a yes-no question, but requires considerations for implementation. Discussions on the workgroup also identified several of these implementation considerations, some of which have been discussed already, ensuring supply, ordering, and provider readiness for an equitable distribution of the vaccine. Next slide. Communications is also integral for equitable implementation, creating COVID communication plans that understand existing data around attitudes and perceptions for COVID vaccines and adjusts actions accordingly, leveraging trusted partners to deliver the vaccines as well as trusted messengers to communicate with a broad population. Next slide. So the workgroup reviewed the totality of the data presented today. And while acknowledging some, so as a reminder, this was the summary of the workgroup judgments for ETR. Next slide. Then as they reviewed the totality of the data presented today and acknowledging uncertainties around aspects of the data, they felt that the desirable consequences probably or clearly outweighed the undesirable consequences. Next slide. And the workgroup proposed to ACIP to recommend the intervention. Next slide. So then the question to ACIP, that we'll turn it back over to you guys, is should the updated or bivalent vaccines be recommended for persons already recommended to receive a vaccine booster dose broadly? Very specifically pointing out the votes for today would be for the Moderna vaccine in 18 and over and the Pfizer vaccine in ages 12 and over. Thanks.
Thank you so much, Dr. Oliver. We can now proceed with a robust discussion. Oh, apologies. Robust discussion of the question that's put on the table. Should updated/bivalent vaccines be recommended for persons already recommended to receive a COVID-19 vaccine booster dose? And actually, I don't see any hands raised, so I was going to actually call back on Dr. Daly, if you're able to maybe provide some thoughts and comments from your perspective.
Well, yeah, thanks so much. I mean, this is in direct response to or thoughts about the comment that Dr. Sanchez made. And I think for me that comment about, lacking clinical data for a bivalent BA.4/5, that is, to me, one of the most important and fundamental sort of considerations and questions for us to discuss today. And I guess my thoughts about that are as follows. I think, and it's something I really struggled with as well, but, in the abstract, if not in a pandemic with 90,000 cases a day or something, I think it would have been better to have clinical data from a bivalent BA.4/5 vaccine. But I would highlight a couple points. I mean, the FDA considered that issue very carefully and met with their advisory committee, VRPAC, and made the decision that they felt it was safe and appropriate and important to extrapolate data from bivalent BA.1 vaccines to this decision. And then they made their EUA authorization yesterday based on that. So I think if we were to ask what would be the harm in waiting for clinical data from a BA.4/5 bivalent vaccine, the idea would be, to me at least, my understanding is we would need to wait till November or December to start a vaccination campaign, and then based on the modeling that we saw, there would be a cost to that, and that cost might be somewhere in the range of 9,700 deaths and 137,000 hospitalizations potentially averted. So I think that is the tension that I feel for sure. But I think I am reassured about several aspects of the bivalent vaccines. I find it quite reassuring that the immune response in general to the bivalent vaccines really does seem more diverse, and I'm hopeful that it'll protect against additional variants. And then there's also sort of a practical aspect to it too for me, which is that given the decisions that the FDA has made, we're now in the position where we have millions of doses of a bivalent vaccine that are ready and available, and I think they're going to be an effective tool for disease prevention this fall and into the winter. So even though I also struggle with the exact issue that Dr. Sanchez raised, those are my thoughts about why I feel like there is, again, this is going to be an important tool to prevent additional disease. Over.
Thank you, Dr. Daly. Dr. Brooks.
Yes, thank you. And my comments address the same issue that was there with that Dr. Sanchez raised. I mean, first of all, theoretically, and I wish I had this slide in front of me, but the BA1, which had clinical, the bivalent BA1, that had clinical data showed activity against BA4 or 5. So theoretically, that I would have thought that might be a vaccine that we would consider for recommendation. The other side of that is that, you know, we've done immunobridging, and that has been done with, you know, vaccines for decades. But I really do struggle with a vaccine that has no clinical data that's reported for humans, for those that would be actually receiving the vaccine. Overall, I have an issue with that, and keep looking back on the BA1 bivalent vaccine and thinking, yeah, perhaps that might have been a way to go.
Thank you, Dr. Brooks. Dr. Long?
Yes, I agree with Dr. Sanchez and Dr. Daly. Come down on the side, I think, of Dr. Daly, mainly because we would have not much expectation that this vaccine would be clinically inferior to what we're already giving. And because it has the potential, I think, to decrease hospitalizations and even deaths. So I think I will reluctantly come down on that side and know that we don't usually have much information, too much clinical information for sure for efficacy when we are thinking about change in influenza vaccines, when it is the same scaffolding, part of the same roof, we're just putting in, some dormers and windows. That's one thing. The second thing I would say is that I'm with Dr. Val and others that I don't think, even though most people would be at least 6 months out, I don't think we want to give the message that this is a 2 month after your primary series or booster vaccine. And on one slide, you said you may want to delay it for 3 months. I would give the feeling that usually this is 6 months after your primary or your last booster, which it will be for most anyhow, and that there would be reasons that you might want to give it sooner, as soon as 2 months. That is, that you haven't had a booster for some time and you're in some risk category, or that I really do want to delay in people who have been recently infected for 3 months. And I'll tell you why that is. It's not only because of what Dr. Oliver says, which I think is true, is that if you wait a little more time, you get a better immunologic response. I am really concerned that there are an awful lot of people who have very recently had Omicron infection. We are now going to recommend this for the group that is at risk for myopericarditis. And we clinicians know that those few patients who got myopericarditis, the adolescent boys who got it after their first dose, if we looked hard and we did serologic tests, we found that they had been infected symptomatically or asymptomatically in the short time before. And then with the added comment of Dr. Fink, that it looks like if you got your second dose in less than 8 weeks after your first dose, you're more likely to get pericarditis. So I want to do no harm. So I like all the things that you said about the 3 months might be there might be reasons to do sooner and later. And as early as 2 months could be justified. But in people who've had infection, I would like that to be 3 months. And I would like the idea to be that this booster is 6 months. And the very last thing, which is all grammar, is although we know you're talking about boosters, even on the slide that's before us, you want to say currently authorized by FDA for booster doses include, because I think people are going to start misunderstanding and wanting to give these as primary. That's all from Sarah.
Thank you, Dr. Long, and thank you for picking up on that as well. Ms. Bata.
Thank you. I have some similar hesitations about moving forward with the recommendation for which we have no human clinical data. I'm reassured by the neutralizing antibody data that has been done for BA.4/5. And I'm also reassured by the hundreds of millions of doses that we've been giving. It's I think that we're being asked to take a leap into a whole new dimension of how we move forward with COVID vaccination, and that's going to be a much more routine cycle of vaccination. And I think that the data that we've had presented is very reassuring, and so it would incline me to support the recommendation in front of us. But I do want to make sure that the concerns that I have are voiced. That's all. Thank you.
Thank you. Dr. Palin.
Yeah, so first I want to say thank you for framing this question broadly. And I do like this approach. I also agree that in the conversations and looking at the clinical data we have, how it compared to animal data, and using that as a bridging does answer a lot of questions for me, and that the modeling data shows it clearly. Waiting to November is a cost in 137,000 hospitalizations and over 9,700 deaths. So waiting for more data is not costly. I remain concerned about saying you can't use monovalent vaccine. And I would really like to understand the thought process behind that and why we're not taking an approach more similar to Canada. Thank you.
Thank you. Dr. Bell.
Yes, thank you. I want to agree with what my colleagues have been saying, and also just on the side of my discomfort, note that the Canadians, the Europeans are using a bivalent vaccine with a BA.1, and it's not clear to me that we have fabulous data about what the incremental benefit is of using a 4/5 as opposed to BA.1, against this somewhat discomfort about recommending a vaccine that we have no clinical data about. Having said all of that, I think there are good arguments for going forward with that. The other comment that I wanted to make is that while I wholeheartedly embrace this idea of being more routine and, we're going to have, just maybe one booster, and that's sort of path forward, as Dr. Wharton outlined at the very beginning of this meeting. I think it is important for people to understand that while we will, we hope that we can go in that direction, and we're all, ready to change the way we're dealing with this pandemic. I think it's important to recognize and to say that things might change. We don't know what the future is going to hold. And while we would like to be more routine, it may be that we, have to continue in this vein, depending on what happens with the virus and with the pandemic. I just don't want people to totally get their hopes up when I think we all recognize that we might not get there as quickly as we would like.
Thank you, Dr. Bell. I'm going to remain optimistic. I'm just going to say, Dr. Sanchez.
So I guess it's my turn. So my concern, as others have voiced, but I guess is that so first of all, it's not that I'm against the bivalent vaccines. It makes sense to have bivalent vaccines. But however, which bivalent vaccine are we talking about? And the data that we have on the B1 is really for 18 and over for Moderna, and Pfizer, we have nothing less than 55 years of age. And yet we're going to make a recommendation for 12 and over. So I have a concern for that. And that is the younger age group where there are, myocarditis is a real side effect. And yes, and so we're then extrapolating the data that has been seen with the bivalent B1 to hopefully similar data for the the B4 and 5. I'm just concerned about that extrapolation, and ultimately, I really don't want to establish a precedence of recommending a vaccine that we don't have clinical data on. And I am concerned about that. So that's what I have to say.
Dr. Lee, this is Melinda Worden. Can I make a brief comment?
Sure, absolutely.
Okay. I just would like to remind the committee that every year we use influenza vaccines that are based on new strains without clinical studies being done. This is what we do every year. We have well-established platforms. There are changes made in the particular strains that are included, but overall the vaccines are incredibly similar year to year. And in a lot of ways, this is really analogous to that, and we've had hundreds of millions of doses of these vaccines used. We've got a lot of familiarity with the vaccines and their performance, and what's happening is a change in the particular virus that the vaccine is targeting that is not a huge one. And so I think the extrapolations that are being made, as well as the preclinical and clinical data that is contributing to this discussion, really do provide a lot of information upon which the Food and Drug Administration based the authorization. And I see that Dr. Fink has his hand up, and he may want to add something to that.
Yes, Dr. Fink, please go ahead.
Thank you. I did want to weigh in on this discussion on behalf of the FDA, and I do appreciate the amount of discomfort that I'm hearing from committee members who are being asked to take this leap with the COVID vaccines that you haven't been asked to make previously with the COVID vaccines, but yet, as Dr. Wharton just reminded us, we do on a regular basis annually with influenza vaccines. And as Dr. Long mentioned with her wonderful construction analogy, these are vaccines that we understand very well in terms of the original monovalent vaccine. And we are talking about bivalent vaccines that are manufactured using the very same process and which contain the same total amount of RNA and are otherwise the same, except for the fact that they now contain two mRNA sequences instead of one. And so FDA felt very comfortable with the approach of extrapolating the safety and effectiveness, or rather the known and potential benefits and risks which underlie our emergency use authorization based on clinical trial experience with the bivalent vaccine containing the BA1 sublineage component, which is also an Omicron sublineage component. We felt similar enough to BA.4/5 to allow us to make that extrapolation. We recognize that we've taken a different path than the regulatory authorities have in Europe and in Canada, but we made our decision based on several factors, including feedback and advice that we got from our Vaccines and Related Biological Products Advisory Committee meeting in June, as well as data that we had toward the beginning of the summer, including some out of South Africa, indicating that neutralizing antibody responses against BA.4/5 natural infection appeared to be more cross-reactive than responses against BA.1 infection. And so for the purposes of improving protection heading into the fall and winter, the best we could against the strain that we knew, the variant and sublineage that we knew would be predominant, we went with the choice of a BA.4/5 component, and we felt confident in that. I also just want to address briefly the concern about extrapolating across age groups. Again, we have a tremendous amount of experience with the monovalent original vaccines in the age groups in which they're authorized. There are some differences across various age groups in terms of reactogenicity profile or immune response, but by and large, the experience and trends are very similar across age groups, and even more so. What we're seeing as we move from primary series doses to booster doses, trends in the exact same direction, no matter which age group you're talking about. And so for that reason, we felt very comfortable taking data from a specific age group, whether it was adults 18 years of age and older, or adults 55 years of age and older, and extrapolating that experience with a bivalent product to authorize another bivalent product, again, manufactured using the exact same process, to authorize use of that product in all age groups. And I think we will be intending to take that approach for consideration of authorizing the bivalent vaccines in younger pediatric age groups once we have product and manufacturing information that would allow us to do so. Thank you.
Thank you, Dr. Fink. I'm just going to jump in really briefly here and let my colleagues know that I would like us, if there's any additional comments, I see Dr. Long and Ms. McNally. I just wanted to say a couple of quick things at the end, but we cannot go backwards and change anything. So I'm just going to suggest to our committee members, any additional comments, please look ahead, look forward. We have a decision in front of us that we need to make, and we can't change what is being put in front of us today. So given all the uncertainties and the recognition that we have to ensure that we make the best possible decision going forward, given all the uncertainties, I'll just ask that we focus the comments on this decision right now. Dr. Long.
Yes, I wonder if Dr. Fink, can you tell us, I don't remember seeing a vote on this by VRBPAC. Was there a vote? And if so, was it unanimous on this authorization?
No, we did not take these authorizations to our VRBPAC. We relied on what we felt was pretty clear advice that we received at the end of June, and also an approach to extrapolation that that scientifically made sense to us.
Thank you. And then my next question, I'm sorry, Dr. Lee, it is related in reference to Dr. Sanchez's comments. And asking Dr. Daly and others on the work group, did you consider at this point only recommending this vaccine for maybe 50 and older, realizing that's where the main mortality is right now, and it would not put at risk the younger people who are at risk for mild pericarditis who may have recently been infected and not need it, not benefit as much as you would think, and two, might be at more risk for mild pericarditis. Did you consider limiting this today to 50 and older?
I don't know what to say.
Dr. Brooks, I'm sorry, thank you. If you want to answer briefly, Dr. Daly, I'm happy to allow you to jump in, and then we'll go to Ms. McNally and Dr. Talbot.
Dr. Long, in response to your question, we did discuss this at the work group, and still came to the general work group consensus that the work group was in favor of this at all ages. Although there were voices that expressed your sentiment too, and that's sort of trying to weigh the totality of the benefits against the totality of the risks. And part of that is looking very carefully at the risk of myocarditis following what we know about the risk of vaccine-associated myocarditis following booster doses to date. And so, yes, it was discussed at the work group, but the work group's general consensus, again, although there were some who expressed your thought too, or who raised that, but the general consensus was to make a recommendation across all ages. Thank you.
So Matt, it's Kip. I was the odd voice. So Sarah, I had the same thought as you, because I was looking at risk of hospitalizations and incremental benefits. And so we had actually talked about, what if you did everyone over 50 or even over 40, those who have comorbid conditions like immune suppression and healthcare workers. And then the concern by the majority of the work group was that then that becomes too complicated and the recommendations are already too complicated. So I think that was the concern of the work group, is trying to keep it simple so that actually people were immunized. Does that summarize the?
Yeah, I mean, I think not just simplicity, but also the feeling that of some members that benefits would still outweigh risks at a younger age. But there's more unknown about the incremental. I think some of this, Dr. Long, is that we don't have great data about the incremental benefit of this for, say, a 25-year-old who's already had maybe 2 doses and a booster plus an infection, for example. That data doesn't exist. So I think I agree with what Dr. Talbot said, other than to also acknowledge that there's more uncertainty about the magnitude of the benefits compared to the magnitude of the risks in younger ages.
Thank you. Ms. McNally.
Thank you. I just wanted to offer some comments for my colleagues to consider. I definitely share in the concern that there is a desire for more information. But as I think about our experience with COVID-19 vaccines over the past several months, it is beyond dispute that we have gotten really good at data monitoring. And that includes the robust monitoring systems we have for safety. And there has been a very clear demonstration of an ability to respond quickly to any issue that has needed to be addressed. And so for that reason, I am comforted by what we're talking about now. And I very much appreciate the comments from Dr. Wharton and Dr. Fink. I do remain seriously concerned about 2 issues, and I want to express those here. The first is avoidable administration errors because of labeling and communication, and the accuracy of the reporting of those administration errors. And I think that I think about this not as much from the medical provider perspective, although that is critically important, but I think about it as the consumer who would potentially have a family member, a child, a parent receive an incorrect vaccination at a very critical time. And so I wanted to raise that point. And the second is continuing to voice concern and appreciation for the fact that this simplified recommendation, even though it is simplified, is indeed a change in a recommendation, and that is complicated for the public. And so I want to advocate that the CDC continue to have clear and accessible communication that remains available for consumers, and also that the avenues for consumers to have their voice heard continue to remain open. Thank you.
Thank you, Ms. McNally. And I will just add a couple of additional comments. Dr. Long, I think I agree with everything you had said. I'm just going to augment what you said earlier, which I think built upon the comments of many of our colleagues who spoke before. Number one, I want to echo what Dr. Wharton mentioned, and actually I think Dr. Lair mentioned at the very beginning, which is this approach is very similar to what we've done for flu. So I don't think this is an entirely fundamentally new approach that we're looking at, but I do feel the same level of I would like to have more information. And it would be better to have more information. But we, again, have this decision in front of us where we anticipate there will be a tough winter season ahead, both with flu and with COVID-19. And I feel our job is to do our best to protect public health. So given that, and given the potential for earlier administration during this season to protect a greater proportion of the population. So I am anticipating effectiveness, and my concern is about missing opportunities for protecting many people. I do think that this makes sense going forward. I also want to emphasize that I feel strongly about reducing and mitigating any potential risks, if at all possible. And so I am going to put out there that my personal preference is to anchor on 3 months as a minimum interval from either infection or a prior vaccine dose. That is what I will recommend to individuals who ask me, but I recognize that there is an authorization out there. I just feel like we've seen benefits and reductions in harms by a longer interval. The third is I want to emphasize again that making access and implementation easier should be a priority. And the final thing I want to mention is, I really appreciate Ms. McNally's presence on this committee. We need to create patient-facing clinical considerations material or a one-pager that would help individuals understand how to maximize the benefit and minimize their risks. And I do think that that's possible. I recognize it's challenging, but many patients are going directly to get vaccines. I always tell people to talk to a healthcare provider if they have any questions, and I know that all of our providers are here and ready to help. But and that includes our pharmacy providers are here and ready to help. I want to be very inclusive, and our public health providers. However, I do think having more information out there can only help. So that is my plea to continue to push that front. Thank you, Dr. Daly.
Yeah, I wanted to jump in again after Ms. McNally's comments, which is just that, I've heard of, and to make a couple comments related, I've heard of parents who've been very concerned about COVID vaccine safety and then have decided to vaccinate, and then only to be told that they were vaccinated with a higher dose. And I think, at some level, we run the risk of losing confidence in the program more broadly the more that happens. And even though fortunately there haven't been serious adverse events that at least have been reported in that circumstance, I think it's critical, and it's not just sort of a simple error that you just sort of move on from for some parents, because then they may not complete the series. And so I'm going to borrow a quote from Dr. Oliver's presentation, although it was in a different context. I think structural problems need structural solutions. And so I think we need to look at structural solutions for vaccine administration errors. And I think we need to, work with the FDA and with the vaccine manufacturers to come up with structural solutions that are not just around education. But then I also think we need to push for continuing to simplify, and simplification may also mean just fewer presentations. And so I think looking forward, I would hope that we could work with, again, the FDA and vaccine manufacturers to have fewer different presentations of different doses for different ages with different volumes and different dilutions and different storage. And the fewer of those that we have, as long as that can be done safely with an effective vaccine, I think, again, less vaccine administration errors, but hopefully greater confidence in the program overall as well. Thank you.
Thank you, Dr. Daly. I'm going to ask Dr. Oliver, are there any additional slides we need to consider?
No, I have proposed vote language, but no new information.
Okay. I actually would really appreciate it if you would be willing to put up the proposed vote language so that we could start to proceed with the vote, because I see no additional hands raised in this moment.
Okay, because there are 2 products authorized. Oh, I did not acknowledge people. Well, maybe there's one more thing I want to say, which is this is, an hours long of ETR presentations plus the extensive presentations and data to inform that are so much a representative of a fantastic team here. So if I'm speaking, it's only because I've got excellent people on my team. So I do want to acknowledge that. Then I will also acknowledge, because there are 2 different products, there are 2 different proposed vote languages, and I can read both of those real fast and then turn it back over to you, Dr. Lee. So vote 1 is that a single dose of the bivalent Pfizer BioNTech COVID-19 vaccine is recommended for individuals ages 12 years and over, at least 2 months after receipt of a primary series or prior monovalent booster dose under the EUA issued by FDA. The vote would also include language to repeal its previous recommendation for administration of the monovalent vaccine for persons ages 12 and over. This is because that product is no longer authorized. And so as it is no longer authorized, we need to replace the vote legally with moving from the monovalent to the bivalent. Then the language for the next vote is very similar, that a single dose of bivalent Moderna COVID-19 vaccine is recommended for individuals ages 18 and over, at least 2 months after receipt of primary series or prior monovalent booster dose under the EUA issued by FDA, and would also replace, this recommendation would replace the monovalent recommendation for 18 and over to mirror what has happened with the EUAs. Thanks.
Thank you. Any clarifying questions to this wording? And for myself, Dr. Oliver, just to restate, there is no authorization that exists anymore for the monovalent vaccine?
In those age groups. So for the age groups where there is a bivalent booster, so Moderna 18 and over, Pfizer 12 and over, for the age groups and products where there is a bivalent booster, FDA replaced the EUA for the monovalent with the bivalent. So we are doing the same, or proposing to do the same with the recommendation. The EUAs are still in place for the Pfizer vaccine for 5 through 11, because that is a vaccine, the monovalent, because that is an age group with which there already was a booster monovalent recommendation, but does not yet have a bivalent product.
We can't hear you, Dr. Lee, if you're speaking.
Oh, yep. I called on you, Dr. Long. Please go ahead.
Oh, I'm sorry. We couldn't hear you. So 2 things on this one. I really think you need booster in there, because people will think that we're recommending a single bivalent as part of extension of a primary series or to complete your vaccination. And so I think I would put the booster I would put the booster after vaccine on the first line. And then the second thing is we're going to stick with 2 months, although I agree with you and I feel pretty strongly that it really should be longer to get maximum benefit and reduce risk. but we're going to leave that to clinical considerations. Was that your idea? And here we stick with at least 2 months. I think it's the wrong message, but it would be, one of the brackets of timing.
Let me first clarify, Dr. Oliver, is there any objection to adding the word booster?
No, we can. The vote language specifically clarifies that it's after receipt of a primary series, but I think for clarification purposes, we'll work on getting booster added. Do you want me to say anything about the interval or?
Yes, please. I would appreciate that.
Okay. So, we absolutely, the work group talked about this as well. I think there are distinct reasons that it is really helpful for the ACIP recommendations in the current setting that we're in, for the recommendations to match the EUA. If ACIP were to vote on a different recommendation, then that would be different than the authorized interval, and it would cause significant confusion and potentially legal issues with the provider agreement, that there would be different intervals recommended by FDA and ACIP. So that's why we've really tried to emphasize that we have in clinical considerations some considerations for longer interval, especially around those who have had prior infection, and that for kind of the population that is at risk for myocarditis, the nearly every one of those individuals is 6 months, if not longer, from their last dose. I will say that this is not meant to imply that people need boosters every 2 months moving forward. As we said, this is a transition point for the program where we're moving hopefully forward, where we're not kind of counting doses with minimum intervals, but may be able to get on kind of a more regular schedule. Fully agree with Dr. Bell that we have to follow the data and that could change, but that's the plan. And so hopefully the future interval is considerably longer, but this is, if we're recommending a time-based program that we think everyone who's eligible should go get this vaccine this fall, the minimum interval is 2 months since your last dose, but most people are longer than that. And it legally is really needs to be in line with FDA. Thanks.
Dr. Oliver, would there be any objection to taking out the words at least 2 months after? It could just be just 12 and older after receipt of a primary series with additional clarification in the wording.
I think our lawyers have weighed in that it's the interval that matches the EUA, I think, is important here.
Don't quite understand that, but I understand that we would say that at least 2 months has to pass, but it would allow us more flexibility to actually provide that information that's needed for both clinicians and patients to understand, if they just had an infection, perhaps more leeway or something along those lines. There's a lot of people who have had recent infection, and I read this as they should be getting it 2 months, even though it says at least 2 months. So this is a legal issue. We cannot change the wording of the recommendation.
It is a PrEP Act liability if the ACIP recommendations are different than the EUA recommendations around specific things like time intervals.
Could I just push this just a little bit more and ask if we're not making a different recommendation, if we simply are silent on the issue of the interval in the recommendation, it's not exactly the same as contradicting the EUA language of the FDA. Again, we maybe are not at, this may not be a very fruitful avenue, but I do wonder if the lawyers might look a little bit differently on this specific issue, which is not contradicting the FDA. It's just being silent on the issue in the language of the recommendation.
This is Melinda Wharton. I appreciate the concerns about this issue. I will remind you all that there are very few people who are within 2 months of getting a recent dose. We're just not talking about many people who are in the age groups that are eligible for this, and realistically, as this goes forward and moves toward publication program implementation, it will have to be in alignment with the EUA. I certainly appreciate the concerns, though, that you all have articulated. I think you absolutely have expressed concerns about those groups of people for whom this may be a more important consideration. And we do have in the clinical considerations guidance about people with recent infection. And I am sure the conversation today has increased the visibility and awareness of those issues, and hopefully people can make decisions about timing of vaccination accordingly. So I don't think we can take it out of the vote, but it's not a requirement for a strict 2-month interval. It's at least 2 months. And again, there's very few people who are within 2 months of getting vaccinated anyway.
Dr. Brooks?
Yeah, just to move it along, 2 things. It will be in the clinical considerations, whatever we want to be in the clinical considerations. And number 2, the words "at least," that covers us comfortably. If you want to do it 6 months or 12 months, we're saying at least 2 months. And I believe it's somewhat aligning with whatever the clinical data that we have, be it from humans or mice. So I'm comfortable with at least 2 months. Underscoring at least.
Dr. Paley?
I wanted to make a motion to accept the vote language. Thank you.
Thank you. Dr. Fryhofer, quick comment. Well, actually, before we go there, sorry, Dr. Fryhofer, I have a motion on the table. I need to ask for a second. Does anyone want to second the motion on the table? Ms. McNally?
I second.
Thank you. We have a motion on the table and it's been seconded. I'll ask Dr. Fryhofer, did you want to make a quick comment?
Yes. Sandra Fryhofer, American Medical Association, but speaking as a practicing physician, I think that keeping the at least 2 months in there is actually very helpful to practicing physicians. I think this discussion to me is so reassuring about how carefully the ACIP members look at these issues, and also points out the importance of the clinical considerations, but to take that out, I think would be more detrimental to what you're trying to help with than leaving it in. So I think leaving the at least 2 months in there, I hope you do that. And I hope you vote for this.
Thank you, Dr. Fryhofer. Any additional comments from members, from voting members? I don't see any additional hands raised. Since there are no hands raised, I'll assume the committee has no objections to proceeding with a vote number 1 here that is specific to the Pfizer-BioNTech vaccine for individuals 12 years and older. I won't read the whole thing. It is there on the slide. I'll ask ACIP members if you would please turn on your video. I will ask you to state your name, I will state your name and whether you have a conflict of interest and then your vote. So I'm just going to go in order of who I see on my screen, and I see Ms. McNally first.
Veronica McNally, no conflict, yes.
Dr. Daly.
Matt Daly, no conflict, yes.
Thank you. Dr. Talbot. Oh, you're muted, Dr. Talbot.
Let me think a little bit longer.
Okay. We'll come back to you. Dr. Sineas.
Sineas, no conflicts, yes.
Thank you. Dr. Brooks.
Oliver Brooks, no comments, yes.
No conflicts or no comments? Oh, you're muted, Dr. Brooks. I just want to confirm, no conflicts?
I'm sorry, did you hear me? Oliver Brooks, no comments, no conflicts.
Thank you. That's what I was looking for, Dr. Brooks. Thank you. Dr. Chen.
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Sanchez?
No conflict, no.
Thank you. Dr. Paling?
Kathy Paling, no conflict, yes.
Thank you. Dr. Bell?
Beth Bell, no conflicts, yes.
Thank you. Dr. Lair?
Amy Lair, no conflicts, yes.
Thank you. Ms. Bata?
Bata, no conflict, yes.
Thank you. Dr. Long?
Sarah Long, no conflict, yes.
Thank you. Dr. Cotton?
Camille Cotton, no conflicts, yes.
This is Dr. Talbot. Well, I'll go before you. This is Grace Lee. No conflicts. Yes, but I still feel strongly about the 3 months. I know that's not really a vote, but Dr. Talbot.
I'm struggling. Dr. Talbot, no conflicts. Yes.
Thank you. I believe we have 13 yeses and 1 no, Dr. Wharton.
That's my count as well. Thank
And
you,
the
Dr.
motion
Lee.
passes. Okay. This vote number 1 passes. Thank you, everyone. We'll move on to vote number 2. I'm gonna try and go in alphabetical order right now. Thank you. Ms. Bata.
Bata, no conflicts, yes.
Oh, I apologize. I did not ask for a motion, and Dr. Paling caught me. Dr. Paling, would you like to make a motion?
Yes, I'll make a motion to accept the language as it's written.
Thank you. Can I get a second? Ms. Bata.
I second the motion.
Thank you. Thank you so much. Thank you, both of you. It's been moved and seconded that we accept vote number 2, which is focused on the Moderna COVID-19 vaccine booster for individuals 18 years and older. So now we can proceed. Oh, any objections, any concerns? We'll proceed with the vote then. We'll start with Ms. Bata.
Bata, no conflicts, yes.
Thank you. Dr. Bell.
Beth Bell, no conflicts, yes.
Thank you. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Chen.
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Sineas.
She's saying that her audio and camera has stopped working, so maybe give her a moment.
Thank you. We'll come back to you, Dr. Sineas. Dr. Daly.
Matt Daly, no conflicts, yes.
Thank you. Dr. Cotton.
Camille Cotton, no conflicts, yes.
Lee, no conflicts, yes. Dr. Lair.
Amy Lair, no conflicts, yes.
Thank you. Dr. Long.
Sarah Long, no conflict, yes.
Thank you. Ms. McNally.
McNally, no conflict, yes.
Thank you. Dr. Paling.
Kathy Paling, no conflict, yes.
Thank you. Dr. Sanchez.
Pablo Sanchez, no conflict, no.
Thank you. Dr. Talbot.
Dr. Talbot, no conflict, yes.
Thank you. And Dr. Sineas. Are we still having trouble? Dr. Sineas, if this is the one exception I will allow for using the chat. If you are able to chat in your name, whether you have a conflict and whether it's a yes or no, I will take that. Dr. Sineas, no conflict, yes. Thank you. This is a one-time exception only for technical difficulties. So I have 13 yeses and 1 no, Dr. Wharton, and vote number 2 passes.
Thank you very much, Dr. Lee. That's my count as well.
Thank you. We are actually quickly running out of time because our colleagues at CDC have a very, very hard stop where the entire audio will shut down. So I will ask maybe just if anybody wishes to express their opinions about this vote, anything different or new, and then I'm going to ask Dr. Oliver just a couple of wrap-up questions before we close the meeting. My warning scared everybody off. I apologize. Any other comments? Okay. I will ask Dr.
No.
There we go. Dr. Long, go ahead.
Sorry. Yeah. No, I wanted to say that as a clinician and making a decision for individuals, I would be on Dr. Sanchez's side. And I make this decision for the best of the most people, considering and hoping that the advantages will outweigh any risks that we do not yet anticipate.
Thank you, Dr. Long. I think we feel similarly. Dr. Sanchez.
So I voted no because I really feel that we need the human data. And that's really, to me, really important. It's a new vaccine, it's a new platform. There's a lot of vaccine hesitancy already. We need the human data. And at the same time, I think that the vaccine will have similar safety as we've already seen with the other with the previous vaccines with messenger RNA. And, I personally, I'm in the age group where I'm at high risk, and I'm almost sure that I will receive it, and I will take it. So I just feel that this was a bit premature, and I wish that we had seen that data. Having said that, I am comfortable that the vaccine will likely be safe like the others.
Thank you, Dr. Sanchez. Dr. Paling.
I wanted to just say that I do think that this is a huge step forward in simplifying the recommendations and hopefully enhancing coverage. It does put a lot of pressure on the distribution of the vaccine because we have now switched from bivalent to monovalent for boosters, people 12 and older. And my sincere hope is that this will be expedient and not impair access for all who want it. Thank you.
Thank you. Dr. Brooks?
Yeah, just two quick statements. First, I really appreciate Dr. Oliver's synopsis. The ETR has shown the beauty of how important that is and the addition of equity on each of the line items because we struggled with equity. And then almost the only reason I voted yes was because of thinking about how we do flu vaccine on a yearly basis. We have data that doesn't show the new vaccine. We just base it on the last vaccine of the last year and determined that it's okay. And safety profile was comfortable. So that was my primary reason for making a difficult vote in saying yay.
Thank you so much. Dr. Oliver, I wanted to confirm, and I know you'll answer in the affirmative, but I just want to confirm that all of the discussion and deliberation will be captured in the clinical considerations to make sure that it fully reflects the diverse opinions of this committee in the vote.
Thanks. Yes, absolutely. The clinical considerations team is hard at work. We'll do everything we can to get everything posted as soon as possible, hopefully within the next 24, 48 hours-ish. But thanks.
It's always a tall order, and apologies that you need to get this out so quickly, but we appreciate how much your team is doing to get all of this commentary in and the opinions of the committee. So we really appreciate that. I want to go ahead and proceed with ending this meeting. So I want to, thank everybody for all of the speakers and our ACIP members, our ex officio and our liaison members for your work today. There are a couple of comments I just want to make at a high level, and I'll turn it over to Dr. Wharton to see if there's any further business. The ACIP, I know on behalf of all of us that we appreciate all of the input today on the booster recommendation, and the hope towards simplification, and the hope that and I will be optimistic, and I can't remember which of the members said this, that we might not be out of the woods yet. I'm going to remain optimistic that this becomes a solution that is one that we can sustain. But as always, I will put in the caveat that if anything substantive changes about the benefit-risk balance, or if there's any new safety considerations, rest assured that ACIP will most certainly meet. And I just want to make sure that the members of the public are aware that we're continuing to monitor closely that with this decision, the decision with NTIR, as Ms. McNally mentioned, we have systems and teams that are continuing to monitor and to meet over time. So I want to, I recognize the uncertainty. I want to acknowledge it. And I just want to say that despite that, I think, we've hopefully made a huge impact in our ability to continue to weather this pandemic together. Dr. Wharton, do you have any further comments that you wish to make, or do we have any further business?
So there's no further business, but I would like to thank the committee as well as all of our speakers and the public for sticking with us today for this very long meeting. I do think this is a big step forward for simplification, and I hope moving towards something that is both a more normal set of vaccine recommendations as well as cadence of changes to recommendations. We're clearly not there yet, but I think this is a big step forward, and I hope we're moving to something simpler that will not require such frequent changes going forward. So thank you all so much. I'm really grateful for your help, and especially to our committee members for all the hard work today. So nothing more, Dr. Lee.
Thank you. Any other objections to adjourning today's meeting?
Dr. Lee, one more point. I've been reminded that some people who were not on at the very beginning may not be aware that we are not meeting tomorrow. That adjourning today is the end of the meeting.
I concur. This would be the end of the meeting. There's no need to meet tomorrow, and I don't see any hands raised. So seeing no objections, I would like to announce that today's ACIP meeting is now adjourned. Thank you, everybody, for your time and all of your efforts. Take care.